Faculty disclosure, the Symposium Planning Committee and speakers have declared no relationships with commercial interests. The program has not received financial support from any commercial organization. The program has not received in-kind support from any commercial organization, and there were no potential conflicts of interest declared. So let's get started. Before I introduce the first speaker, I just want to mention that Manda Bellet will not do a presentation this morning, but she will take part in the panel discussion at the end today. She will be joining us with Dr. Laura Stone, our first speaker. Manda Bellet is a registered nurse working as a collaborative practice specialist at Sault Area Hospital in Sault Ste. Marie, Ontario. She completed her nursing education in Thunder Bay and has worked in critical care units in Thunder Bay, Brampton, and Kitchener, as well as the emergency department in Collingwood, before relocating to Sault Ste. Marie with her husband and dog Bella to enjoy the great outdoors. Our first speaker this morning is Dr. Laura Stone. She is an emergency physician in Sault Ste. Marie, Ontario. She completed her medical school at Western University, followed by family medicine and emergency medicine training at the University of Toronto. She started her career in the emergency department at Credit Valley Hospital in Mississauga before returning to her and her husband's hometown of Sault Ste. Marie. Now with their two boys, they spent their free time enjoying the beautiful Northern Ontario outdoors and all the summer and winter activities it has to offer. Over to Dr. Stone. Dr. Stone's presentation will be called A Practical Approach to Updating the MHP at Your Community Hospital, What We Have Done and What We Have Learned.
Thank you very much, Dr. Roos. Good morning, everybody. Thank you very much for having me. Thank you, ORBCoN, for the opportunity. So I am an emergency physician at Sault Area Hospital, and I am chair of our Transfusion Committee, which is how I became involved in updating our massive hemorrhage protocol. As Dr. Roos said, Manda is one of my wonderful nurse colleagues. She's been a huge help with this presentation. She has been involved in this whole process right from the very beginning, and so she will be available for questions later on. So I do not have any disclosures today, apart from a reminder that I am not a hematologist, and I am also not an MHP expert by any means. We certainly have many of those experts on the call today, but I have gone through this process over the past few years with my incredible team, and I'm very excited to share with you what we have done, and hopefully that will help you at your hospital. So I'll take you through how we brought together our working group, how we used the toolkit recommendations and applied them to our hospital, how we rolled out education, and then I'll talk to you about the debrief process, which is where we are at right now. So first, just a little bit about us. We are in Sault Ste. Marie. We serve the Algoma district, which is about 115,000 people. We are the largest hospital in the Algoma district. We are a ways away from our other large centers. So we are a 7-hour drive from Toronto and about a 3-hour drive from Sudbury. And Sudbury is our closest trauma center, as well as our center for vascular surgery and neurosurgery. Apart from those specialties, we are a fairly self-sufficient hospital. Our GI manages most of our massive GI bleeds. Our obstetricians manage our massive OB bleeds. And we do keep some kind of single system trauma, but in general, a big multi-system trauma, we would transfer out to a trauma center. So given our location, this means that we do need to stabilize patients before we transfer. It will be at least a few hours typically before we can get a patient out, and sometimes longer, particularly in the middle of winter. And so that means we're generally following damage control, resuscitation strategies. We are stabilizing these patients before we transfer them. So for example, for a trauma, say an intra-abdominal trauma that requires an MHP, that patient would come into our emergency department. We would stabilize them there as much as we can initially. We would activate the MHP. We would do our definitive hemorrhage control, whatever that means we could do in the emergency department. And then the patient would go to the operating room. And our surgeons would do kind of a damage control surgery. The patient would then go to the ICU, and our ICU would manage the patient before they are transferred out. So our location does give us a bit of a challenge in this regard, in regards to patient care. I can't help but give a little plug for Sault Ste. Marie while I'm here. Our location does give many advantages as well. We are on St. Mary's River, which gives us direct access to Lake Superior, Lake Michigan, and Lake Huron, which is pretty awesome. 40 minutes to our west, you can be on the shores of Lake Superior. About 40 minutes north, we have Searchmont Ski Resort, which has a 700-foot vertical, which is about the same as Blue Mountain. Of course, it's not as developed, but we had great snow this winter, and there are no lines. And we have, of course, the North Channel to our east with amazing boating and cottage country. And then this is Hiawatha here. That is 5 minutes down the road from our hospital, with amazing mountain biking trails and snowshoeing and cross-country skiing in the winter. So if you want to come on a cottage vacation or a ski vacation and do a little work while you're here, we would love to have you. Please reach out. So a few more things about our hospital. We are on Meditech, and so this was a big consideration when building our MHP. All of our orders are electronic, and all of our documentation is electronic as well. And finally, a little bit about our blood bank. It is a busy service. We do stock plasma, and so we were able to include plasma in our MHP. And we had about 25 codomegas last year. So hopefully that gives you a bit of context as to who we are and what resources we have. And so we'll start right in as to how we started updating our MHP. So as you know, the toolkit was released in the spring of 2021, and it was this fantastic resource, essentially how to provide comprehensive care for the massively hemorrhaging patient. It was fantastic. And I will say, selfishly, particularly for myself as an emergency physician, something that was going to make it easier to provide care and allow us to provide better care for the patient rolling into the emergency department was very exciting. Our whole team was excited, and we were all on board and ready to get going. So we did have an MTP in place already, which was called overhead as an Omega alert. The emphasis was really just on blood product transfusion. We had adult and OB order sets, but nothing for pediatrics, nothing on our EMR. We had no education established, and nothing, no reference material that we could easily reference. So we started off by creating a working group. We initially started talking about this at our transfusion committee, but it quickly became apparent that it was too much to try to tackle there. And so we created a separate working group. Physicians involved were myself. We had Dr. Coate, who is an ICU physician as well as general surgeon. So he was a wonderful resource. And then we have Dr. Pendergrast, who I'm sure everyone knows here well. He helps us from UHN and works closely with Barb, our MLT. So he's always a wonderful resource for our transfusion committee, but he was also very helpful during the rollout of this MHP. We had our nurse educators involved from the emergency department, ICU, and women and children's program, and they were invaluable in this whole process. They were the ones who really dissected the toolkit and all of that incredible information, and then synthesized it into our policy and our protocols. And they, of course, took care of the education aspect for the nurses. And they are now heavily involved in the debrief process. So they have done an incredible job and a ton of work on this over the past 3 years. We also have our collaborative practice team. So they're the group in our hospital that works on quality and best practice. They work on communication kind of throughout the hospital. And they were really the overall group who tied everything together. Amanda Mather has done an incredible amount of work, and now Amanda has joined her team. And they were really essential this is such a multidisciplinary endeavor, and you really need a group to tie everyone together, help with that communication, and know the ins and outs of the hospital and what needs to be approved and where does that go for approval. So they were also very helpful in this. Of course, our lab was involved. Barb worked hard on this with her team in association with Dr. Pendergrast. Our IT was crucial in developing our online order sets from scratch, which I will talk more about. And then we also included some kind of experts at our hospital. So for example, Allison is an anesthesia assistant. She had been involved in many MTPs as they were prior to this update. And she was involved in getting our first MTP up and going, and had already been doing education in our OR and with our OB group, and had already been kind of taking on that lead nurse role. And so she had great experience at our hospital and was an excellent resource. So I certainly would encourage you, when you're building your working group, make sure you get your clinical educators involved. Make sure you get your version of collaborative practice to help you tie everything together, your lab, of course, and your local experts. They will all make your job a lot easier. And to quote my little guy in kindergarten, whose favorite line is "teamwork makes the dream work," truer words have never been spoken. And certainly, in addition to our working group, there were so many people at our hospital who had eyes on this, and we had support from every level, including the senior leadership team all the way down. And I think it is really important to get a lot of people involved. It will really help with your buy-in and will help with a smoother rollout. So once we had our team established, we looked at the toolkit and tried to take all of that information, tried to look at where we wanted to go, what we had, and then decided kind of what we needed to do to fill in those gaps. And so, oh, sorry about that. So we identified our kind of overall goals. We decided we needed to update our policy. We needed to create new protocols for adult pediatrics and OB. We wanted to create some bedside reference tools so that all of this fantastic information that we were working so hard to incorporate into our protocols was easily accessible at the bedside. We knew we had to build these electronic order sets, and then we wanted to develop staff education. So with that, we got going. We updated our policy and we set to work on our protocols. We did change the names to MHP and code transfusion, as was recommended in the toolkit. And we really used this 7T framework. We loved this. Again, kudos to the team who did this toolkit. The 7Ts really highlighted the fact that transfusion is one small aspect of caring for these massively hemorrhaging patients. There's so much more that goes into it. And the 7T framework very clearly illustrated that. We at Sioux Area Hospital actually made it the 8T framework. We included transfer of accountability. We know that this is a high-risk time when a patient is handed over from one team to another. And as I gave the example initially of a trauma, we do have a lot of handovers in our hospital. Initially, as the patient rolls into the emergency department, it would be our emergency team and the emergency physician who is running the MHP. I would then hand over to, say, the anesthetist in the operating room, who then hands over to the ICU physician, who is then handing over to the transport physician. And so we very much wanted to highlight the fact that we need to be very careful and very deliberate with these handovers and the transfer of accountability. So we used this 8T framework in everything that we did. We structured our policy and our protocols around it as we did our education. And then we went through every T as we were constructing the protocols and decided what we wanted to take from the toolkit and what would fit our hospital. So we really used most of the recommendations from the toolkit, so I won't go through most of them in detail. We did focus on team, and we did modify the transfusion piece, and so I will talk about those a little bit more. So in regards to team, the toolkit, said we should have well-specified team roles. Absolutely. They had the team leader role, the nurse lead role, and then kind of other nurses. So we took it a little bit further and really specified and defined those nursing roles and really broke down what everybody should be doing in the room. And we did take this as kind of an opportunity to really work on our team dynamics for all codes. These resuscitations in general are very complex. They are chaotic often in the room. And so these particularly really highlight the need for well-defined team roles. And when I have to apologize, this is my drawing, a little thing that I used for education. It's terrible. It's the extent of my computer skills. But it kind of got the idea across that even down to where everybody was standing in the room was helpful. When I was at shock trauma in Baltimore, they had squares on the floor, and depending on your role, you stood in your square and you did not leave your square. And of course, it's not like that in our recess rooms, but just giving people a general idea of kind of where you were in the room helps others when they come in the room know, even if you don't know any of the nurses, you kind of have an idea of who's doing what. And so this is a picture of one of our emergency department recess rooms. And so the general idea, again, as we illustrated in the protocols, and then as we tried to get across in education, was that the lead physician and the lead nurse would be at the foot of the bed here, kind of running the resuscitation together. And we decided, because everything is electronic, we would need to bring a second computer into the room, and the lead nurse would be on the computer entering verbal orders, on the phone with the lab, with the porter, reviewing blood work that was coming back, etc. So they're kind of the overall lead team. We talked about and defined the second MD role as being the procedural MD, and very clearly educated and defined this as the physician who's trying to achieve definitive hemorrhage control. Their job was to stop the bleeding. So whether that be a tourniquet or a pelvic binder or balloon tamponade of a GI bleed or obstetrical bleed, that was their job, and of course is of utmost importance in an MHP. And then we broke down the other nursing roles. So we have our bedside nurse here, who would be up giving things like calcium. And then we have our blood team. So our nurse on blood, just hanging blood. So over here with our level 1 transfuser, focused on hanging products quickly. And then we created a separate nurse documentation role. So it's, so often, say in a code blue, your lead nurse will also be documenting. We found we did some kind of mock scenarios myself with our nurse educators as we were developing this, and we found it was actually way too much for the lead nurse to try to be documenting as well, particularly because the blood has to be all documented on the computer. It's a bit more finicky, and the lead nurse was already too busy doing everything else. And so having this as a separate team over here on this computer, hanging blood quickly, documenting what blood products are going in as well as other medications, seems to have worked well. And then, of course, we have our team outside of the room as well. So in regards to the transfusion aspect, in the toolkit, it recommended pack 1, pack 2, pack 3, pack 4. We were able to include plasma because we do stock it at our hospital, as I mentioned. Regarding the terminology, we talked about using either the term pack versus cooler. We were already using the term cooler. Our staff know what it means. It's the cooler arrives in the room, and so we stuck with that. And we did decide to simplify it a little bit. We used the terms initial cooler, standard cooler, or custom cooler. They're a bit more explanatory in what they meant, we felt. Our initial cooler is our first cooler, of course, and it comes with 4 units of pack cells, and it includes 4 grams of fibrinogen concentrate automatically if it's an obstetrical bleed. Our standard cooler contains 4 units of pack cells and 2 units of frozen plasma. And then our custom cooler is a cooler that you can order whatever components you need based on your lab results. And we did reduce the amount of plasma in the standard cooler. And so, as I said, we stock plasma. We have 12 units of frozen plasma, but we are a distance to get those restocked. So they're either coming from Sudbury, which is going to probably be 4 or 5 hours, or Brampton, which is probably 10. And so we did have to keep that in mind. And we felt that reducing the plasma in that standard cooler meant that plasma still would be available if we needed it, but it reduced the risk of wastage. And then we did remove the fibrinogen from the standard cooler. I think that was a resource issue or a consideration, as well as our lab feeling more comfortable if it was ordered when we needed it. If we ran out of frozen plasma, the plan would be to go to SD plasma. And then I don't think we've ever had to go to PCC, but that would be the plan if we did run out of plasma. For the pediatric transfusion piece, we kept it the same as was recommended in the toolkit. We did remove the fibrinogen concentrate from the third cooler because this requires approval, apparently, and we didn't want it to slow down the delivery of other blood products. So once we completed our policy and our protocols, we really wanted to create a reference tool that we could use at the bedside to make sure that all of this great information that was in the toolkit and that we had worked so hard to put into the protocols was actually translated into great patient care at the bedside. You know, if you've been involved in a resuscitation, you know that it's impossible to read through a document during that time. And we don't do these that frequently, right? We had 26 MHPs last year. That's a couple a month. And as a physician, I might be involved in only a couple a year. And so to have a memory aid available to make sure we're providing the best care that we can for our patients was very important. The toolkit did include this checklist, which was great. The concern from our point of view was that we were going electronic and we were trying to get away from paper documentation, and we felt like this might lead people to document on paper, which was not felt to be the best option. The toolkit included this algorithm, which was beautiful. It had, you know, all your quick reference information at hand. And so we used this to create our own quick reference. So this is ultimately what we came up with at Sioux Area Hospital. We put a lot of work into this, and ultimately Dr. Coate, again, who was our ICU physician and general surgeon, and also has experience in graphic design, apparently, pulled this together for us. And it's one of the things I'm most proud of. You can see it is structured again around those 8 T's, so really highlighting their importance. It has our hospital-specific information, such as extensions, and then it takes you through your reminders of sending off your initial blood work, checking that temperature, making sure your patient stays warm, giving your tranexamic acid early, and we move to that 2-gram bolus, which is fantastic. A reminder to call your friends early to help with definitive hemorrhage control, your anticoagulant reversal. And then it reminds you of the transfusion piece. So it gives you the contents of your initial cooler, your standard cooler, and then your custom cooler. Constantly reminds you to ask yourself, can this be terminated? If the answer is no, you're giving more blood products. A reminder to change to your lab guided transfusion as soon as possible, and a reminder of your targets there. A reminder to repeat your blood work, check your last blood work, and then again, ask yourself, can we terminate now? If not, you're going back up to give more product. And if you can, then a reminder to do a really good handover. So this is an official hospital document, meaning it is easily accessible. It will be updated. We disseminated this to all of our physicians, and so everyone has it on their phone. I have it on my phone. I have used it in MHPs. I used it once when I responded to an MHP in a labor and delivery room, and at that time we didn't have these blown up, and it was incredibly helpful. Even myself, who's so familiar with this from looking at it for so long, in the midst of a chaotic resuscitation, it is so helpful to be able to look at something and think, yep, okay, we've given tranexamic acid, you know, et cetera, et cetera. Have we checked a temperature? When's the last time we checked that? And I also love the fact that we have enlarged these. They're laminated in all of our recess rooms now, in the OR, on the OB floor and ICU. And I love that in that way, they're not just for physicians, they are for everybody in the room. And the whole team can look and follow along and help out and say, hey, Laura, have we given tranexamic acid? And I would say, no, we've forgotten. Thank you so much. Let's add that now. And so it just empowers everybody in the room to be on the same page and to make sure we're doing those 8 Ts, which are so important. We have a similar document for pediatrics with just the pediatric coolers and their targets. And one for OB, the only difference being that 4 grams of fibrinogen concentrate is included in the first cooler. And we are more than happy to share these with anybody. If you'd like to use this as a starting point for your bedside reference document, we're more than happy to share. Please reach out. I certainly would encourage you to create something for your hospital. I think they're really helpful, especially for those of us who we're not doing these every day. So after we did our policy and our protocols, we had to get those approved. And then our IT group started on the Herculean task of creating electronic order sets from scratch. This was amidst Meditech expanding from 3 sites to 23 sites. And our EMR expanding from our acute areas to outpatient areas. So they were very busy. They had a lot on their plate. It took them almost 2 years to finish this, but they did it, and it turned out really well. So I'll take you through just a few pictures of what it looks like. Most of these orders during a resuscitation are going to be put in as verbal orders, but if I was putting them in, it would look the same to myself as I pulled it up. You search MHP or MASS, and it comes up as either adult, pediatric, or OB, so you click on whichever order set you need. And then we use these drop-down menus. So for labs, you can either choose your initial labs, Q1H or Q4H labs, and they automatically populate. Similarly with coolers, you choose the drop-down menu and you have your initial cooler, your standard cooler, or your custom cooler. Grab a drink. For our pediatrics, it's similar as well. You can choose the weight range, and then the cooler is automatically populated for the blood components for that weight range. And when you put in the child's actual weight, then all of the dosing is automatically calculated, which is nice. And the nice thing about the order set is it does work as a checklist. So if I'm at the foot of the bed running the resuscitation with my lead nurse and they're putting in the verbal orders, they would see a line that says tranexamic acid. And my nurse would say, oh, hey, Laura, have we given this yet? And I would say, no, thanks, let's add that. Great idea. And so again, it's just another way to make sure that we're not forgetting anything for these patients. Similarly, you have that line, is the patient anticoagulated? You would choose, yes, they're anticoagulated with warfarin, and you can choose your vitamin K and your PCC. And finally, we have room for our adjunctive medications as well with reminders. So for example, what we're targeting, a calcium over 1.15, and we're giving calcium after at least every 4 units of packed red blood cells. And our protocols are attached to the electronic order set, so they're easily referenced if necessary. So while we were getting these order sets built in the electronic world, we started on education. And so this brings us to kind of last summer and the fall of 2023. So we started with the modules that were created by ORBCoN, and we modified those for our hospital. Collaborative practice, as well as our nurse educators, were huge in this. Collaborative practice really helped with communication throughout the entire hospital, communicating these changes, passing on the educational piece. And then a real win for our hospital, something again we're very proud of, was that our senior leadership team approved 4 hours of paid nursing training for our nurses in the emergency department, the ICU, OB, and the OR. And this was really huge. This is a lot of information, a lot of updates, including all the order sets on the EMR. This education was huge in making making sure that we had a smooth and successful rollout. So our nurse educators did an incredible job with this. The nurses were required to do their online learning module ahead of time, and then they got a quiz and were given copies of the protocols so they could be familiar with those ahead of the sessions. This was the itinerary for that 4 hours. So they really focused on going through the protocols, so they were familiar with those, the team roles and the importance of knowing your role. Of course, electronic order sets they went through, and then they had time for hands-on skills. So working, reminder of how to mix the fibrinogen concentrate, how to use the pressure warmer, the pressure infuser and warmer, et cetera, et cetera. And then finally, they finished with 2 simulation sessions, and physicians were invited to drop into these as well. So this was a really robust 4 hours, and of course, given that it was paid, we were able to train all of our nurses with great uptake, and again, it's been huge in a successful rollout. In terms of physician education, I took this on primarily. I started with emergency department rounds in the spring of 2023 and continued into the fall with more presentations to my Emerge group. I spoke with our pediatric department, our OB group, and Dr. Coate, who was our ICU physician and general surgeon, he spoke with our surgery and anesthesia groups. And then we did a bunch of simulation sessions. So we've done a bunch of sims with our Emerge group. We did a big joint anesthesia and OB sim in one of our labor and delivery rooms, which was really fantastic. And we actually identified a number of process improvements that we could make, including OB did not have an MHP tray. And so they wanted something created where they had all the tools they needed for an obstetrical massive hemorrhage readily available, which was a huge improvement. And then we've done pediatric sims as well. So I look forward to hearing from Dr. Petrosoniak. He is one of our sim experts, and we certainly are excited to do more sim at our hospital to continue education going forward. Again, in the physician education, I spoke to all of the 8 Ts. They are all important, but I did focus on the triggering aspect, because that is a tricky part of these MHPs, knowing when to activate. And we know there's a lot of scoring systems out there, but me in the emergency department, I just want to know from a practical point of view, what am I doing when this person comes in massively bleeding? Am I starting an MHP or not? And this critical administration threshold I really loved. And again, kudos to Dr. Petrosoniak and his team. I know there's many others on his team maybe here today, but they have published some fantastic kind of articles that are practical and to the point and really helpful. And I use them a lot in my physician education, both for my own education and then for disseminating to my colleagues. And I did, I use this idea of the critical administration threshold in the emergency department and advocated for that to be used in our hospital as well. In general, of course, there's always going to be different considerations, but in general, when a patient comes into the emergency department and they're bleeding and unstable, I should back up and say over the past few years, we have actually changed the process at our hospital. So based on an EMS patch, so if I get a call from EMS and to our emergency department saying they have a bleeding and unstable patient, we can get 4 units of uncross-matched pack cells down to the emergency department before they even arrive, which has been fantastic and has really sped up our time to transfusion. So as the patient rolls through the door, they're bleeding, they're unstable, we hang a unit or 2 of blood, and that gives us a bit more time to assess them and see what's going on. And then once we're on that 3rd unit, we start to reassess and think, are we going to need more blood products? Are they still bleeding? Are they still unstable? If the answer is yes, then we would go ahead and activate our MHP. And if the answer is no, then we've avoided activating that MHP. which is a big deal, particularly at a hospital like ours, where when we do activate an MHP, it's very resource intensive and it's taking a lot of people away from other things that they could be doing. So we don't want to overactivate, and yet we want to avoid underactivation. And so this critical administration threshold is fantastic, very clearly illustrated by Dr. Petrosoniak. And then I think Andrew may have coined this phrase. You'll have to correct me if I'm wrong, Andrew, but this is from MRAP in November of 2022, the rule of threes. So once at three, think ABC, think about activating your MHP, balancing your blood products, and starting to give calcium and your concentrates. And so again, such a great memory aid. I use it. I encouraged all of my physician colleagues to use it as well. And I would say if you are doing some physician education at your hospital, look for these resources. They really are fantastic. And again, with the education, I did focus on team, really trying to emphasize the fact that as the lead physician, your job is to really organize your room and to try to remember those roles. And education will be ongoing, as we know. So our go live occurred December 2023. So about 2.5 years after the toolkit came out, we celebrated for a brief moment and then dove right into debriefs. And our working group became our debrief team. After our first couple MHPs, we did some informal debriefs and quickly learned a few lessons. We realized that it's very hard to get everybody at the table, but very important. And we needed a more formal process in order to try to get everybody to the table. And then we learned that we really need to break down these MHPs, get the data as to the times, like where was the blood at what time, to really figure out where you can make some process improvements. So we created a more formal process for getting everyone to the table. So now when a code transfusion is called, our MLT starts the documentation with their times in the lab. It's given to collaborative practice, who then sends it out to the unit leaders and the clinical educators. And then those leaders contact frontline staff, get their feedback, invite them to the table, and a debrief is scheduled within 10 days after the code transfusion. So this has been more successful in getting everyone to the table. So we also created a debrief tool. We used the 8 quality metrics from the toolkit, which were fantastic. We added this additional metric of pack cells issued within 10 minutes of protocol activation to really understand when did the blood leave the blood bank, and then, compared to when did we actually start that transfusion. And that was helpful. We also included porter documentation times. So when the porters received the call to get the blood, when they arrived in the lab, when they left the lab, and when they arrived at the code transfusion. And that was, again, really helpful just to find out where was that blood at certain times. And then, of course, we record who was involved, all the great things that we did, and we celebrate those, and then also identify the educational opportunities. So there have been 7 code transfusions since we went live in December. We have learned a number of things. First of all, all of our initial kind of educational emphasis and focus was on the main areas where we felt these MHPs would occur, like the Hemorrhage, the ICU, the OR, and OB. Of course, in our first 7 code transfusions, we've had a few that have happened on the floor, the medical floor, and so that identified some issues. One of them was difficulty just drawing blood work on the floor. We needed more hands. We also didn't have the labels or the equipment that we needed to get that blood work. So we've included now a phlebotomist actually automatically responds to all of our codes now, which has been a huge improvement, and that's just helps efficiency overall. We realized we needed more pressure infusers, and so those have been ordered. We realized we needed to expand education to our medical nurses as well as our medicine physicians, and so we have done that. And then the importance of the roles keeps being emphasized, and so we know that that's something we need to keep working on, really establishing those clear team roles. And overall, we know these are complex resuscitations. We've learned that really breaking them down helps. We know education will be an ongoing process. We know that when things break down, it often comes down to communication. And these debriefs have been a great opportunity to really work on that communication really throughout the hospital. Because these are so multidisciplinary, it is bringing groups to the table that don't typically come to the table. And, you know, for example, for myself as an emergency physician, I just stand at the bed and say, where is the blood? Why is the blood not here? And I before had very little understanding of what was happening in the blood bank and the challenges and stressors that the porters experienced during this whole process. And so being able to hear from all the different groups involved has been really fantastic and really helps everybody understand that at the end of the day, we're all just doing our best. We're trying to do the best that we can do. And we're all working together towards that common goal of providing great patient care. So that is how we have rolled out the MHP at Sioux Area Hospital. I think overall, you know, start with an amazing working group, include your nurse educators, your version of collaborative practice at your hospital. They will make your life much easier. The toolkit is fantastic. Thank you, ORBCoN, for putting that out. And so use it and pick out what works for you for your hospital. Education, as we know, is so important. It will be an ongoing process. And if you're lucky enough to have hospital support, as we were very lucky to have at our hospital, it really helps with a smooth rollout. And finally, go live is just the beginning. The debriefs have been a lot of work, but they have really uncovered a lot of opportunities for improvement at our hospital. So once again, I can't thank my team enough for doing all of the work on this and doing an incredible job. And thank you to all the people involved at our hospital who looked at this at one point or another. There are a few of our references, and I look forward to hearing your questions or further feedback at the panel. Again, Manda is extremely knowledgeable on this, and she'll be able to help out with any questions you have as well. Feel free to reach out if we can do anything to help you. Thank you very much.
Well, thank you, Dr. Stone. That was absolutely amazing and indeed super practical. Our chat is overflowing with requests for your algorithms and your quick reference guide, which is so helpful because you're absolutely right that nobody has time to go through 8 or 10 pages of a protocol at the time when it happens, especially if you don't do it all the time. So that was truly amazing and extremely good resource for not just smaller hospitals, frankly, but all hospitals to look at. So thank you. And thank you also for your segue into Dr. Petrosoniak's presentation, who's next. Dr. Petrosoniak is an emergency physician and trauma team leader at St. Michael's Hospital. He is the inaugural lead for translational simulation at Unity Health Toronto. He is an assistant professor at the University of Toronto, where his research work focuses on, first of all, using in situ simulation to improve systems and design, and secondly, optimizing the care of bleeding patients. Dr. Petrosoniak is a co-founder of Advanced Performance Healthcare Design, a design and consulting firm that uses simulation to inform and enhance high-stakes decision-making. Finally, when he's not working, he balances chauffeuring his daughters to dance performances and cheering for the Raptors, despite their awful record. That's his saying, not mine. Dr. Petrosoniak's presentation is entitled Bringing Your MHP to Life, the Rollout, the Logistics, and the Training. Over to you, please.
Great, thank you for having me. I'm guessing I can just take over sharing the screen, is that right?
You should be able to.
Great, perfect. And can everybody see that okay?
Yes.
Yeah, great. Well, thank you very much. Yes, I am missing a dance performance this morning, but I would certainly, if I'm going to be doing something, it's talking about MHP. I love talking about this type of stuff. And I just want to say what an amazing talk this morning by Dr. Stone. I'm not sure that I'm going to top that, that's for sure. But hopefully what we talk about here kind of builds on that. And I mean, the amazing work that they've done. I hope, you know, if you're working on taking, you're bringing out your MHP and bringing it to life, hopefully taking notes and reaching out to her and her team. because the work there that they've done is really impressive, and it's great to see that the toolkit helped to support that, and some of the work that's been done by many people at ORBCoN to kind of make this happen. This is where I work. And so it's weird that I was asked to give a talk about rural hospital MHP implementation. And I acknowledge that. I work at St. Mike's Hospital downtown Toronto, where we have a very active MHP. We have for many years, and it's been led by Dr. Katarina Pavinsky, who is just an amazing and huge advocate and impressive human, rolling out MHP at our hospital and leading it across the province. But more recently, over the last few years, actually, I've been working more frequently, a couple shifts a month. I'm an Hemorrhage doc, and I'm working now in two places, Haliburton and Bancroft. It's close to where I grew up. And so I've gained, at least I have a little bit of street cred, not a lot, not certainly as much as the folks on this call that are working in smaller centers and looking to implement, but I understand and appreciate the challenges. I understand and appreciate what resources are available in smaller centers and what aren't, and this has certainly helped me hopefully be a little bit more grounded and understanding of what's needed. And it's been an incredible work, and I've just came back from Bancroft last week working a shift, and have a few up in Haliburton coming up. So this is what we're going to talk about is using a framework to think about how we might be able to bring MHP into our institution at a bit of a higher level. Obviously, Dr. Stone gave that very granular and detailed approach, and I would encourage people to reach out for particular questions, because I think she probably has answers to how that can happen. But let's zoom out a little bit and think about just how you might be able to take some first steps at this, if you wherever you're at in your with your MHP at your hospital, whether you haven't yet considered to implement, or you're pushing near the end and you're just trying to get across the finish line. This is a patient that I think many of us may see in a smaller center. And to be honest, most of the MHPs in smaller centers, outside of any large academic center or quite large community hospital, by and large are going to be trauma patients. They're certainly going to be seen in the ED, the odd obstetrical hemorrhage. But let's talk in the context of trauma, because I think that's what most of us will experience. A patient who's 64 years old with an MVC, involved in an MVC, has an altered level of consciousness, presents with tachycardia, hypotension, and a positive FAST. And this is not a clinical talk, but the idea here is that it's fairly clear that this patient's bleeding. And that recognition happens and is taught to physicians and nurses and respiratory therapists who would be at the bedside to recognize that. And it's with that recognition that we might make a decision to activate MHP. I'm not going to talk about, how we make those decisions, but let's imagine that decision is made. Well, unfortunately, at this hospital, we'll call it Hospital X, there is no MHP. And so they do try and get a couple of units of packed red blood cells, but it's delayed. Unfortunately, everybody's was so focused on getting the packed red blood cells that there was a delay in sort of organizing the transfer. A patient's temperature was not recorded. The TXA unfortunately was forgotten. The patient didn't have a great outcome. They survived, but it wasn't as streamlined, and there was certainly more bleeding than expected. A longer hospitalization, and then obviously there were follow-up meetings in terms of trying to adjust this. And this is a hypothetical case, but I think that this type of thing, before the work that we started doing back in 2018, these were things that would happen. And perhaps still do, but I think to a large degree, far fewer. But this highlights kind of how this can quickly, without some structure in a complex patient, in a setting where there might be 2 or 3 nurses, a single physician, this can quickly become challenging. And so how might we approach this rollout? And I'm going to take a step back, and this is a great tool when you're thinking about change management. And this is Cotter's change management framework. We're going to work through this as we start to think about the case that I just presented and work through these 8 steps. And each of you, depending on where you're at with your MHP rollout, with your development, you will be at different stages. You know, some of you may be early on, not yet contemplating even that the MHP is needed at your institution. Some of you might be running simulations the way that Laura described and near the end, and it's quite refined and you're regularly debriefing. But I think that each of you will be able to find a spot and something to take from this. And so the first kind of element of change, if you're really working early to get an MHP, to get buy-in for this, is really creating that sense of urgency. And that case that I just described, as you start to review it, hopefully would be an anchor for creating that urgency. And we look to cases, to examples, to situations where there have been problems. And we use that to help create that urgency. Particularly in centers where we don't have it happen very often, where we need to activate MHP. It sometimes can be difficult to really galvanize a team around something that happens so rarely. But if we start to, if it does happen, and there maybe either there is a good outcome or a bad outcome, but an outcome that we think that there's opportunity for improvement, then we have that opportunity to leverage that urgency to start making headway and moving forward. And I'll be honest, you listen to Dr. Stone talk about the work that their team did, and we know it can be hard. It sounds like a lot of work that was just done. We recognize that. And these are the challenges that people tell us when they're trying to implement. There's clinician time. Can you get funding for clinicians to do this type of work? There's perhaps limited MD availability. It's a rare event, so why do we want to put our resources into rare events when we know how difficult healthcare is right now in Canada? It's, there's so many things that are happening on a regular basis that we want to be able to do better. How can we allocate resources to an MHP that may happen, several times a year at our institution? And then just whenever you're trying to change things, there's those upfront friction costs, those things that can just get in our way, whether it's, hospital bureaucracy, whether it's more meetings, whether it's just too busy on a clinical end. And that sometimes just, it can feel overwhelming. And these are the things that people tell us. And it's true, but creating that sense of urgency and then parlaying that into coming together and finding a few key people, and forming that coalition, that powerful coalition. And it might just be 2 people. It might just be you and your colleague who realize how important it is. And if you can do that and start that and be positive about what value this is going to bring, then it's amazing what can happen. And when we come together as a team and we see people who are enthusiastic about an initiative, then we can really leverage the idea of FOMO. This is what social media sort of has made its. There have been billions of dollars made by Facebook and Twitter and X or whatever it's called now on Instagram on the idea of missing out. We don't like missing out, and so let's be a part of that community, both on a local level and on a more provincial and a national level. And I want to share with you what it's like being a part of that community. And I'm going to share with you some of the amazing work that's happened over the last 5 years. And we would love for those who haven't yet delved into this to join us. And for those that have, thank you. And this is how it started. In 2018, across the province, we had 65% of hospitals with an MHP. And through the incredible work of the entire ORBCoN team and our MHP 1.0 team at the time, led by Jeannie and Katerina, we've now scaled up to now 77% of hospitals in in Ontario have an MHP that aligns with what we've put out from the ORBCoN and the toolkit and the recommendations. And that's amazing. And what's even better is that the denominator here has actually grown for, there's been additional hospitals added. And so we started with 97 hospitals, and now we have 122 out of 159 hospitals who have an MHP that aligns with the recommendations that we've put out. And even better is that there are hospitals who are actively working on implementing their MHP. So 95% of hospitals in Ontario have or are implementing, they haven't yet fully been able to sign off on it, but they are working on doing so. And so there's just a few percent left that we want part of this amazing community. And for those that it is possible. I mean, we heard from Laura, though admittedly she's in a, certainly a bigger center than the centers that I work in, where we just have a few units of packed cells. We wouldn't have plasma, and we would be administering, far less units in a year. But smaller hospitals have gotten on board. 74% of small hospitals, less than, I think, 5,000 units a year is what we define being transfused. They have gotten on board with this, and so it's possible. And it's great to be a part of this. And so once we've formed our coalition, we can see the community that we're going to be a part of, both locally and regionally or provincially or nationally. Then we can start to create a vision for change. And where does that vision for change start? Well, it might start with a case, that urgency that started, but it might then also come from understanding, why is this valuable? Well, we know it's hard, right? Getting diamonds from the earth is not easy either, but when you have it, once you've mined it, it's a beautiful thing. And an MHP that's functional and delivering care for a patient that's bleeding, that needs that care, that is a beautiful thing as well. And so why does this matter? Well, there's a few things that matter. We know that for every minute delay to blood at the bedside for a bleeding patient, there's a 5% increase odds of death. So an increase of 5% for every minute delay of getting blood to the bedside. If you can nudge that down, and we've done this work at St. Mike's a few years ago, we were able to decrease our time to blood delivery by several minutes. Now we're regularly within the between 5 and 7 minute mark to blood delivery at the bedside. We are meaningfully making an impact on patient outcomes. We know that getting early TXA saves lives. And within an hour, and particularly for small hospitals, and this is, in the context of trauma, getting early TXA to patients saves lives. And so if that's the only focus you want to take, hey, we will support that. We will applaud you for that. If you can get 2 grams of TXA into these patients, it really does, it does impact their outcome. And we know that minutes matter. And so by prioritizing these small little gains, that's absolutely key. The other thing that we know is we want, we focus on temperature control, increasing by just a degree, closer to 35 to 37. Any degree increase, we can decrease the need for blood transfusion, and ultimately it's associated with decreased mortality. And so simple things like this makes a difference. And by having an MHP, this is what the data tells us. We decrease blood product usage, we decrease wastage, we decrease length of stay, particularly in the ICU, we decrease complications for patients, including need for dialysis, and we increase survival. And so what better data do we need? We know how valuable this is, and this is something that we can do in our hospitals, big or small. And I firmly believe, just like in the Field of Dreams, if we build it, they will come. And if we build an MHP, if we start the process, we make it important at our institution, people will jump on board. The great thing is that there's a community of hospitals around the province who have come together already. and have implemented this, are sharing ideas, are sharing their data. And if you build it at your hospital, I promise you we will help support that. And here's a map of, where we continue to target and try and get everybody on board. You can see where there are MHPs across the province and where there aren't. And we're continuing to reach out to your hospital. And if you have no MHP at your hospital, or you're looking for help, please, we want to be part of that. We might direct you to, so reach out to ORBCoN. We want to be a part of your success. We may direct you to success stories like the folks from Sault Ste. Marie, and or other examples that would resonate with you. And we know that there are people, we've heard about the success that's possible, and we can make that happen. Now, how do we communicate that vision, right? That's step 4, communicating the vision. Well, some of you might be asking, well, why do I even need this at a small center where we don't do this very often? Well, there are meaningful things that can be done. You might be thinking, well, I'm not a level 1 trauma center. We don't see that many. We only activate an MHP a few times a year. We only have a few times where we transfuse blood in an emergent setting. Why is this important to me? And I've talked about what impact that can have. But the first thing is understanding, what is it that we're talking about? We're talking about an MHP, and you've noticed that terminology has changed. This is no longer just about giving packed red blood cells. This is no longer about just giving FFP or platelets. This is about taking care of bleeding patients. And so what can that look like? Well, there are 5 big areas where particularly in smaller centers, you can have such value to the patient's outcome. You can recognize bleeding early. You can give a couple of units of packed cells early. You can give TXA early. You can arrange early transfer, and you can get early point of care testing. If you focus on those 5 things, that would be a huge win. It may be overwhelming to focus on every aspect, but 5 key elements that will add value to your organization, and it will no doubt bring great value to the bleeding patients and their families that come into your hospital. And so how do we empower that action? Well, we need a starting point. And I'm a big fan of, 1, delegating and empowering people to be able to work on their own, do their own good work, and starting and eliminating red tape, and making sure that they have, if they have great ideas, bring that forward. It's amazing to hear the folks in Sault Ste. Marie, how they've taken some of our materials and adjusted it and made it relevant for them. And that's exactly what we want to have happen. And particularly in your own institution, if there's somebody in your blood bank, or if there's a physician or a nurse that is passionate about this or has interest in this, give them an opportunity to succeed. Give them a platform and make that canvas a blank slate so that they can jump into this. And we've created a toolkit. It's there. The information is there. It's a starting point for you to take this information. And this is how we sort of describe, a way of approaching a rollout and implementation. And you may feel like even this might seem too much, and that's okay. And this is some idea of how we might advise, going through the toolkit, checking it against what you do exist at your existing site. We talk about meeting with the hospital steering committee, the MHP steering committee. Well, if that steering committee might be you and one other person meeting at Tim Hortons for a coffee, great, that's perfect. It doesn't need to be overly formal in the early stages as you develop this. We want it to be simple. We want small steps towards great things. And then obviously, yes, it will, as the MHP, like any protocol, will need to get approved by your hospital to roll out. But we really try and emphasize that if you have great ideas and you use the toolkit, that you can customize it for your own institution, and hopefully that work is less than what you might imagine. And it's absolutely key to create quick wins. And those quick wins can galvanize your team to be enthusiastic in the future. And when we think about quick wins, we think about just taking that first step. If you can do one thing together as a team, you've created your coalition, your powerful coalition, you have a vision, you know what it is that you want to do, it still may feel overwhelming. It still may be difficult. And so if you can just latch onto one component that you want to focus on in your MHP, do so. That will then lead you to the next thing. If it's just getting TXA in for all of your bleeding trauma patients within, 15 minutes of arrival, then that's a win. That's huge. And so if I were in a situation where I was thinking about, I'm working in a small center, I'm trying to devise and come up with an MHP for my center, and I'm busy. I don't have a ton of time to allocate to this. I'm going to pick a few small things that I want to focus on, and these would be early TXA, early RBCs, and early transfer. And with this, now it's suddenly an overwhelming, seems like a lot. I have to implement into EMR and all of this stuff. It now seems a little bit more manageable. And taking these small steps, these bite-sized pieces to make it manageable really is absolutely critical. And then you can build on that change. You take those quick wins and you showcase that at your institution. If you can gather some data and you can show your hospital administration the work that you've been doing and the partnerships you've formed and the alliance that you're with the rest of the hospitals in the province, I can guarantee you the administration will be excited about this. Everybody wants to be part of something great, and I strongly believe that that's what we've created here. And we do have spelled out order sets, and it seems like a lot of work to go and create your own. And so you can take this and drop it into your EMR. You can adjust it accordingly to your own institution, but you can make some small tweaks. But it's far easier than starting from scratch, because now we have a framework. And I'm a big believer of this. And I think that in healthcare, unfortunately, all of us, or many of us, are really focused on achieving perfection. That's why we're in healthcare. We want the best for our patients. And that can certainly be true, but we certainly can be okay with good enough for the short term, and we can strive for perfection in the long term. And honestly, if this is from Atomic Habits and James Clear, this idea of small gains. If you can get 1% better every day or every month, every year, then that grows exponentially. And so if you can just make small changes to your MHP and just make it a little bit better than it was the day before, then you will have for sure exponential growth by the end of the year and by the years to come. And then, making it stick, for some of you, you may already have this in place. You may have an MHP, you're collecting some data, you're reflecting on it. I mean, what do we do now? Well, I certainly love the idea of, the work that I do is often centered around simulation. Simulation can be overwhelming to run. A large scale simulation, mannequins, it seems like a lot of work, and it certainly it is. But you can do small things where you gather people around a tabletop. You actually omit having a mannequin, but you go down to your an OB room in your hospital, or a resuscitation or trauma room in your hospital, and you simply go through the process of, imagine we have a patient here right now who needs an MHP. How would that play out? And simply just going through the steps. You don't need a patient in front of you. You give a quick scenario. You imagine, okay, where are the phone calls that need to happen? Is the porter going to move the blood? How is that going to happen? How do I interface with my transfusion lab? How does that blood come back? Did we streamline the process at our institution? When we did this a few years ago, we realized our porters were taking the elevators, And the elevators at St. Mike's might be the slowest elevators in the world. We're working on a Guinness acknowledgement through that. And so we were shocked, but we had never asked. We had never asked the porters until we ran a simulation, and they told us they didn't realize that it was a life threatening priority that they actually move, through the stairs and rather than through the elevators. And they, as a result, changed, and that whole process changed. But because we took time to ask and we took time to understand people, and we can do that by just simply using what we call, a pluralistic walkthrough, which is a fancy word for a bunch of the team coming together, and basically just walking through the steps and seeing where the pinch points might be and seeing where the things that you're doing exceptionally well. If you want, certainly we can scale up, and this is some work that we've done a few years ago. We've put on YouTube one of the simulations, and I apologize. One of the things that we need to do better is to run this and make it. This is a MHP that we ran at our hospital at St. Mike's, but this doesn't necessarily look like a small rural hospital, and so we need to deliver on that, and we'll work on getting a simulation that is more relevant for more folks in the province. But you can see here, 2.7 million views. A bunch of people have seen this, which is amazing, and hopefully something like this can inspire you. If you can't run a simulation yourself, then sit down together as a team and use one of these videos. We have a medical MHP as well as a pediatric one on YouTube that you can sit down together as a team and just watch it and walk through map your own MHP onto this and see where we can do better. I mean, we're not perfect in this. In fact, we had a few problems. We didn't check the wristband of the patient before administering blood. But there are always ways that we can get better. And if we can get 1% better, it's going to be amazing. And so if we go back to our case, after doing this, and we've created an MHP at our hospital using this framework, this same patient comes in a few months later at Hospital X, and hypothetically there is now the MHP, and we can give 2 grams of TXA immediately. We can get 2 units of packed cells. We don't actually have plasma at this hospital, but that's okay because we're getting some volume in the form of packed cells. We get it within a few minutes. There was an early temperature check, and the plan is to continue to monitor that. And because the process is working much better, the team has some allocated resources to actually make a call to critical a little bit earlier, initiating that transfer. We get some labs drawn their point of care. That's great. No problems. We can actually act on some of those. And this translates to a big win for this patient, for their family, and for the clinicians who are involved. And so one thing, this is what I'll leave you all with, is do one thing. Make a commitment to do just one thing when you go back to your institution, whether it be a meeting to initiate an MHP at your hospital, whether it be to run one debriefing in the next year in 2024 at your hospital after an MHP, or to run one simulation or walkthrough, or you pick, but do one thing. And by doing that one thing, it'll give you one small step towards building out an MHP that really works for your institution, that's customized, but also harmonized with what we're recommending across the province. And with that, I am going to stop. I hope that you can take some of these ideas. I love using the Cotter's change management as a way of as a framework to kind of to bolster how we might be able to implement change. I know how difficult it is in hospitals and healthcare these days to do big things, but we can really be part of something great. We have created an amazing group of hospitals who have come together. We're starting to put in data. We have we have 95% of hospitals are implementing or have implemented an MHP. And by doing so, people from around North America are looking at this type of work. I promise you, we were at a conference down in Nashville last year, and the Americans were envious of this because of the work that we were doing, and we were presenting on how we have rolled this out. And it is something to be proud of For all of you who have done this work, thank you. For those that are looking to do this work, please reach out. We're happy to help. We do have some resources, and we're happy to connect you with folks that have had success at their local level.
Thank you very much, Andrew, for that amazing presentation. I think that anybody on this call is already convinced that you need to have an MHP if you don't already have one. But to have all this information to help you convince leadership and colleagues in the hospital, if you still need that, but also to have all the information on how to make things work is extremely helpful. And again, your name is on so many publications we know related to this. I hope people have a chance to look at those as well. So thank you again. A reminder that all questions need to be put into the Q&A. Don't put them in the chat, please. If you have a question for the speakers, it should go in the Q&A. We're now going on to our third and last speaker for this morning, Dr. Michael Peddle. Dr. Peddle graduated medical school from Memorial University of Newfoundland and completed an FRCP in emergency medicine at Western University. He's a diplomat of the Royal College of Physicians and Surgeons of Canada with an area of focused practice in pre-hospital and transport medicine. Mike has worked as an emergency physician at London Health Sciences Centre for over 15 years. In addition to emergency medicine, his career experience spans both land and air pre-hospital transport systems, as well as emergency preparedness and response. He is the Associate Medical Officer for Operations, Education, and OCC, and works clinically as a transport medicine physician at Orange. In addition to his work at Orange, he is also an associate professor at Western University, a physician with the Provincial Emergency Medical Assistance Team, or EMAT, and the medical director of the LHSC Emergency Management Program. Over to Dr. Peddle, please.
Well, good morning, and thank you for the invitation to speak today. Looking forward to passing on a little bit of information about how Orange can integrate into some of the great work that has already been sort of discussed this morning. And so only disclosure for me, I am a paid employee of Orange. I'm the Associate Medical Officer, as mentioned, and also not a hematologist. So I'll limit my commentary about the transfusion piece to what I know, and go and hopefully speak mostly about the aviation piece and how we integrate. So a couple of our objectives today, really to hopefully get people, allow people to understand how Orange works and how it integrates into the system, and really how that will help bleeding and traumatized patients within Ontario. I'll briefly discuss some of the clinical evidence for pre-hospital transfusion, talk a little bit about how we're going to integrate and some of the pieces of integration of Orange into pre-hospital transfusion or interfacility transfusion once we're involved, and talk a little bit about where we're going with pre-hospital and transfusion in Ontario. So a couple of polls. I'm not sure if the poll system is going to work today, but I did include a poll. Is the poll system? Oh, there we go. Poll system there. Excellent. So we'll quickly throw a poll up there, see where people are coming from. Excellent. So we've got a good distribution of people across all of Ontario. All right. And so let's move on. And so one of the questions that we often get is where did you come from when we show up on some of these themes? And so just to provide some context for people as to, how the system works, where we come from. So this is London-based. As you can see, they're primed and ready to go for the next call. Aviation is a very different world than the land EMS system. London-based actually is one of our fastest responding bases. Not surprisingly, you can see it's pretty well set up there. But you can imagine that starting one of these vehicles is a little different than starting a car or a truck. takes a few minutes to get through your checklist and get things started, and then you still require ATC clearance before you're allowed to even move, let alone take off. And so we are about, from the time T0, from the time call comes in to the time that this aircraft is off the ground, our median time is about 18 minutes in London, which is about as fast as you can do it. Our shoot time, as in engine startup and starting to talk to ATC, takes about 8 minutes from the time the initial call comes in to the time that we can be dispatched. So just to provide some aviation context. So where did we come from? So if you look across Ontario, we're fairly well distributed, and the bases are specific to the geography that they service. So we've got 14 bases across Ontario, of which we have 8 fixed-wing aircraft in a 24-hour period, servicing primarily the northern parts of the province. And then in the southern parts of the province, more distributed between helicopters and land assets. So we have 8 rotor wings and 5 dedicated CCLA bases, 2 of which are 24 hours and 3 of which are 12 hours a day. So I'm going to briefly talk about how we got there. There's really 3 ways that we end up moving patients. So the first is the scene call. And really, these ones are the ones that you're not going to see from a hospital perspective. If CAC gets a trauma, what sounds like a trauma patient, or the patient is identified as meeting the field triage standard by paramedics on scene, they can auto launch us towards the scene, and we take that patient directly to the lead trauma center. So I'm going to describe it more with pictures than descriptions, but essentially this is what happens. We show up on scene, we pick up that patient directly from where they were and take them directly to the lead trauma center for that geography. And so this is really where the initial part of Blood on Board, or our Blood on Board program, came from, was for our scene patients. And so I'm not going to spend too much time talking about the research behind it, but as Andrew said, there's a lot of good evidence that suggests that reducing time to injury from injury to MHP has a significant outcome in hemorrhage-related mortality. And I actually had the exact same quote in here. For that odds of mortality going up by 5% for every minute delayed in initiating your MHP. The evidence for pre-hospital transfusion is a little more variable, in that not all studies have shown a significant outcome for blood in the pre-hospital setting. There's a couple of studies, one by Brown in 2017, which did show a reduced 24-hour, 30-day mortality in pre-trauma center RBCs, and then PAMPER is probably the biggest study that showed reduced mortality with pre-hospital plasma transfusion or blood products. But other studies like Refill and Combat actually didn't show a significant benefit to having blood in the pre-hospital field. Despite that, we've obviously moved forward with our Blood on Board program with the idea that really we know that getting blood to patients it seems to make a difference. Certainly, there's some evidence to suggest it makes a difference, and there's other intangible benefits to having that blood on the aircraft. And so, currently, we use the Credo ProMed coolers. They store 2 units of O-negative RBCs, and those coolers can store RBCs in the 1 to 6 range for up to 96 hours, actually a little bit longer than that. But we have had them go a little bit longer than that, but ultimately we try not to go beyond the 96 hours. And we have processes set up to exchange these coolers 3 times a week. Usually we do Mondays, Wednesdays, Fridays, which keeps them well within that window of 1 to 6 degrees, so that if the blood is not used, it can go back into circulation. We look at our data over the last couple of years. So Blood on Board at 799, so that is our Toronto helicopter base, has been ongoing since 2021. We've had 100% reconciliation of all of our transfusions between our file, our EMR, as well as the Sunnybrook lab information. Transfused over 100 patients in that time frame. And there's been a lot of blood back and forth between Sunnybrook and the base. So in 2021 to 2022, so from September 2021 till the end of 2022, 1,200, just over 1,200 units were transfused back and forth, of which we transfused 109 units to patients. And there were 10 units discarded due to out of range or log tag issues. In 2023, 484 coolers, 968 units back and forth between the bases. We've transfused 98 units in the calendar year. And I'm happy to report that we did not, based on some of the changes we made in 2021, 2022, we did not have a single unit that had to be discarded when it was returned to the transfusion lab. So every unit was able to go back into to the hospital system. We've expanded blood on board to our 790, so that is our Thunder Bay base. That is our biggest northern support base. It has 2 fixed wings that run 24/7, as well as a rotor that runs 24/7. We went online in April of 2023. Similarly, I'm happy to report we've had 100% reconciliation of all of our transfusions. We've transfused more than 20 patients since April. Up to the end of the year, and we have more coolers going there, so we have just over 1,300 units in that time frame, 61 units transfused, and we've had 9 units discarded. Operations out of our Thunder Bay base are a little different than Toronto. Fixed wings have longer distances to travel, so some of the things we've seen there is unlike Toronto, where it's generally shorter transports and the crews are taking 1 cooler and using between 1 and 2 units per patient. In Thunder Bay, some of their transport times can be 2 to 3 hours after patient contact. So sometimes they'll take 2 coolers and actually have up to 4 units to transfuse with these patients. The other part of it is what we call a duty out, not to get too aviation specific, but crews can only fly for a certain number of hours, and once they reach their end of duty day, they're not allowed to take off. So I won't say quite frequently, one of the challenges within that operation is crews getting stranded or having to stay somewhere else at the end of the day. And so in the calendar year, we had 63 crews ended up not being able to return to base, and therefore the coolers not being able to come back on the Monday, Wednesday, or Friday scheduled time. But of all of those 63 coolers, only 1 cooler ended up going out of range because it didn't get back to base, and that was a weather-related issue. The crew got stranded for 3 days away from base. So happy to report that not only are we making patient impact with this, but we're not significantly impacting the system from a units lost or discarded because they aren't being able to be replaced back into the system. So now I think I'm going to spend a bit more time just talking a little bit about modified scene and the interfacility process, because this really is where Orange starts to integrate into these massive hemorrhage protocols that are being developed by some of the facilities. So we get a lot of questions about what is a modified scene. And so I'm going to show you pictures instead, but essentially a modified scene is we still launch, but we don't get the scene. Often it's because the crew has already left scene or there's some challenges landing at scene. And so we come to the hospital, pick that patient up, and then bring them to the lead trauma site. So essentially, similar to before, we're sitting at base, we get launched, but we go up there and for whatever reason, we can't land. So what do? We divert, we go to a helipad. There's a number of helipad sites around the province, either at hospitals or not at hospitals, where we can land and crews can then hand off to us. And then we bring that patient to the lead trauma center. Finally, and this is probably even more so impactful for the group on the line today, is the interfacility piece. So you have an accident, a patient comes to your hospital, and then to Andrew's comment, you start to arrange transfer through Critical. And so once Critical calls us and pushes that information to us, we send the helicopter or airplane or CCLA to then move that patient. And so that's where we get our OCC involved. So this is a picture of our dispatch center on Explorer. You can see a number of our staff. And I always like to put a little plug in for what that process looks like, because I know there's lots of questions about sort of what happens and why does it take so many phone calls and what are those phone calls. So Critical pushes the information directly into our system, and that allows our medical call taker to then reach out, get the clinical information that is relevant and required for the transport, so we can decide what is the most appropriate asset to send to that patient. And then as soon as that medical intake is done, it gets pushed to our TMP, and then finally over to our planner, who you can see is sitting just on the other side of our medical call taker to dispatch the most appropriate asset. And I think that is where we really see the integration piece. And the key part to it that I say is Blood on Board is not just about trauma, and it's not just about pre-hospital transfusion. It's really about how we can help manage bleeding patients as part of trauma. And so what we recognize going into this is many locations have limited blood supplies, or in the northern areas where we service have no blood available. And so being able to bring blood with us is an important part of treating patients and or shortening their time to transfusion. It also allows us to integrate into the transfusion practices that you see at some of the hospitals. I think this is where my next poll question is about sort of what, from an experience perspective, the group on, what kind of blood products do you stock? All right. So it looks like the vast majority of the group, at least, have more than 5 RBCs on site. So that's great. And then my next question is, how about some of the other products like plasma, PCCs, or fibrinogen? Right. And vast majority have all of the different tools within the MHP protocol. Great. All right. So let's chat a little bit about how do we integrate. So when the MHP toolkit came out, one of the first things that we did from an Orange perspective is actually integrate it into our medical directives and standing orders. And really so that we can integrate and be part of that process. And when we show up, because we recognize we're showing up in many cases, things have already been initiated. And so what we want to be able to do is speak the same language, have the same terminology, understand what the teams are doing. And so we built then a MHP medical directive aligned with the toolkit. So talking about being the first pack being RBCs, then including calcium, either gluconate or chloride, depending on what we have access to, the reassessment piece as to whether or not you need to continue with blood. And if we are continuing with blood, adding in things like fresh frozen plasma, but also recognizing that not all places will have thawed plasma for us. And so being able to use prothrombin complexes or fibrinogen as an alternative to that. And then continuing on into third pack platelets if need be. And so the question then becomes is how then do we integrate? And I think there's a couple of important limitations to recognize when you look at Orange and how we work. And so the first challenge with integration is space. So this is the back of our helicopter. And recognizing that we can't bring everything, one of the major limitations in aviation is not only the space, but the weight and balance. There's a long-standing running joke in the transport medicine world that you will never build an aircraft big enough that the medical team won't fill up with stuff and the need for stuff. And so that means realistically, what we bring with us is 2 units of packed red cells, maybe, and we'll talk a little bit down the road about some thawed plasma with it, but we don't have everything. And so that means we're going to depend on the sending site where we're picking up these patients to provide us with some of those tools to be able to continue the care of those patients. And so I really like Andrew's slide on the sense of urgency, as well as his the 5 things of like early recognition, early intervention, and early transfer. And so I'm going to add on to that the idea of early integration and early planning. And so what I mean by that is the time it takes to get some of those products available from your labs for either you to provide to the patient in that timeliness idea, or to provide to our crew to use for transport takes time. And in looking retrospectively at some of our data, we know that delays in product result in delays in transfer to delays in departure for our crews, which really means a delay to arrival at definitive care. And so I think recognizing early that, you know, a patient is going to require a massive hemorrhage protocol is important. And then if you know that patient's being transferred, recognizing that part of that that protocol is going to be done in transport, and having those products readily available for our crews to be able to take with them is a great piece of how we can integrate and align practices to result in timely transfer and care of the patient. So quick last question for the group is, have you had the experience of preparing blood or other blood products for Orange to transfer? And I recognize that sometimes the lab people may not know if that blood is actually going with Orange or just going up to your transfusion, up to your emergency department. Great. So certainly the majority have had some experience with it. There's a number of groups that have not at this point. So, all right. So one of the final challenges, and this is something that I wanted to bring to this discussion, is utilization and the cold chain associated with our blood products and waste. And so from our Blood on Board program, one of the things we've pushed very hard for is to minimize waste, and our program KPI was less than 1% unit discard rate, because we recognize that RBCs of any sort, let alone O-negative RBCs, are a scarce and vital resource that we don't want to impact significantly. And so within our program, we have a very strict process to monitor and maintain those coolers. We have validated the fact that those coolers can be out for 96 hours. We validated the fact that you can open the cooler, take out one unit, close the cooler, and that the other unit in there will still maintain a 1 to 6 degree range for the entire duration of the cooler until it's returned to the lab. But that's not necessarily the same as the coolers that are being brought up to the emergency departments for our crews to take with between facilities. And so what I can say from a training perspective is we've done a number of simulations with our crews on how to integrate into MHP, how to manage our cooler bags, the fact that you take some of the key pieces that we've worked on them is only taking out what you need, keeping the coolers closed so that they maintain their temperature. And ultimately, sometimes we use all the products we get, but not all of the time do we use all of the products that were provided. And so the last piece of that integration is actually handing off the the leftovers or the unused components to the receiving trauma center for ideally return to their stock or utilization on the patient if they feel it's important. But I recognize and I've been involved in a few conversations that is sometimes a challenge within the system to accept those blood products into the lead trauma center's blood bank because of the cold chain custody piece. And so I think that's an opportunity where we can continue to grow and improve our integration so that we can minimize loss of any blood products within our system. So what are some of the other things that we're working on? So expansion is one of the biggest things that we are working on within the program. As I said, we have launched in Thunder Bay and are looking at our other fixed wing bases. I'd like to highlight this picture. So the picture on the right there, where you can see the aircraft designation along with a building behind us, Fort Severn. So Fort Severn is our most northerly continually inhabited community in Ontario. I like to highlight to people that if you live in the 401 corridor, you are currently closer to Jacksonville, Florida, than you are to Fort Severn, Ontario. And so that is some of the distances that these crews are transporting. That aircraft had come out of Thunder Bay. It's about an hour and 45 minutes, depending on wind, up to Fort Severn, and then give or take, depending on the receiving center for the patient, anywhere between an hour and 45 to 2 hours to their destination. The goal of our Blood on Board program is eventually to be across the entire system. So we're working with our other fixed wing as well as rotor wing bases to bring those online. We've started to collaborate with groups to look at pre-hospital transfusion. So far, a lot of our work has been looking at the system in Canada, working with CanPat, which is a group of transfusion and transport organizations to look at how that happens across Canada and developing some protocols for the use of blood in the pre-hospital system. And the next big thing is SWIFT. And so for those that have not heard about SWIFT or know about SWIFT, so SWIFT is a UK study looking at whole blood in frontline trauma. And so we are moving forward and hoping to go online very shortly with the SWIFT study. So currently it's a multi-center unblinded study being done out of the UK, New Zealand, and hopefully shortly Canada, looking at 2 units of leukoreduced whole blood, O negative or O positive, still working on that, versus a control of 2 units of RBCs with plasma. And so that is where we are. The participant inclusion criteria are very simple. It's a patient who has suffered a traumatic injury. They have been attended by our air ambulance team, and they require pre-hospital blood. And so we are moving forward with that, hopefully coming out shortly in the GTA area, and then we'll see where things go from there. And with that, I'm gonna leave it open to questions. I'll put it up there, my email there, in case people have specific questions or challenges that they would like to address. And that's it for me.
Thank you very much, Dr. Peddle. We are now ready to go to the panel discussion that will be led by Dr. Jonathan Mack. And if you have questions, please put them in the Q&A. You still have a chance to get those answered.
Great, thank you, Dr. Roos, and thank you to all our speakers. My audio is coming through okay. So we're starting the panel discussion a bit early. We might be a bit ahead of schedule on the agenda, but I'm sure, I don't think anybody will disagree with that. Just as a reminder for the panel discussion, we're encouraging everybody to submit their questions. If they have any additional questions that haven't been submitted for the speakers, into the Q&A, and that can be done, I think, a little differently depending on which system you're using. At the bottom of the Zoom screen, you'll see a Q&A button that you can click on. That'll open up a window, and you can enter your questions there. If you don't see that Q&A button, you can look for the three dots, ellipsis, and if you click there, that more option should show up, and you can enter your questions for the speakers there. While we're giving some time for people to add in some questions, we do have quite a few questions for the speakers. Before starting with the questions, I just wanted to introduce, I think Manda is joining. I'm not sure if Manda, if you've joined us yet, or if she's, are we too far ahead of schedule, and should we wait?
Nope, she is on. And,
perfect.
Her bio was read at the beginning of the session.
Excellent. So welcome, Amanda. She's going to help out provide some of the nursing perspective from Sault Ste. Marie, which is fantastic. So great talks from everybody. I think just to open up the questions, a question for Dr. Stone, or for Amanda, I guess, just about runners for blood at your hospital, and what stakeholders that your hospitals utilized as the runner during the MHP code.
Laura, do you want me to take this one?
Sure, go for it.
Okay, so we use porters, our portering system here at Sault Area Hospital. So the stakeholders that we involved were the manager of the portering system. They are involved in our debriefs as well. They touch base, and they will record all of our metrics in terms of time arrived to lab and time to the MHP.
Okay, perfect. And it looked like they were fairly well integrated into the multidisciplinary team. It's really nice to see the really impressive integration at your site for all the different key players in the MHP development. A question from, not in the chat, I guess, just kind of a question I had about things was, developing these MHPs obviously takes so many key players, and I think the steps you mentioned were having, the champions identified. Once you've identified the champions, what did you find was most effective in terms of motivating that next tier of participants that needed to be involved? I think you have the people who are really motivated, and then you need that support staff and getting those people motivated. Like, what did you guys find was most effective in getting that motivation?
I guess I'll start from I think a physician point of view. I mean, I think just talking, I think that was part of my role, was reaching out directly, that one-on-one communication, and talking to people in regards to what was applicable where they worked. So for example, talking with our anesthetists, what was going to be helpful for them in the operating room, what was going to help them run these massive hemorrhage protocols. And again, from them, they wanted a quick reference where they could look at the lab targets really quickly. So I think it was reaching out to everybody specifically and finding out what would help you run these MHPs in a better way. Amanda, feel free to add.
I totally agree with that. And I actually really can't stress enough having a physician champion such as Dr. Stone, who really kept us on course and really kept us focused, was really important. Involving the transfusion committee, and then involving our leadership, and keeping everything sort of on course that way. Amanda Mather, who is my colleague in collaborative practice, was really so important in keeping us on track and keeping the work at the forefront. And then that sort of trickled down through to the other stakeholders.
Thanks. A question for Dr. Petrosoniak, I think, is just around patient temperature monitoring, and what method you think is best used, your recommendation for that when the patient's intubated versus not.
Just any device, honestly, like, just getting some sense of what patient temperature is. Tympanic is probably what most people are doing. I mean, if you have a patient that can kind of cooperate with an oral temp as well, one of those two is fine. I think ideally, if they're intubated, then it really should be esophageal, some type of invasive monitor. But I think the fact that we're having this conversation is what's probably most important. The idea that we're acknowledging that temperature matters in these patients is key. If you're off by a degree, you know, I don't think that's a big problem. I think it's mostly sort of understanding a trend. And if you're regularly monitoring these patients as they sit in your ED or your obstetric unit or your OR, then that's really the most important thing. And if you're identifying that they're hypothermic at any point, then starting some degree of warming processes. So honestly, just whatever you have, make it as easy as possible. I'm all about reducing friction.
Great, thanks. Just a reminder for anybody, we're trying to encourage us to keep the flow of things. If you have any questions, try to just put them into the Q&A just so we can keep a steady stream and minimize too many disruptions with speaking, etc. Question for Dr. Peddle, I guess, just to shift over to you. Some questions came up about the idea of the cost of patient transport, approximately. Do you have any kind of ballpark figures of what the pre-hospital transport costs are?
I can tell you it's dependent on the mode of transport, and that rotor wing is more expensive than fixed wing, and all of which are more expensive than our CCL8 ones, but I don't have the numbers on the top of my head, so I'd have to go get them. I can try and track them down for this afternoon.
Super. A follow-up question for you on just on the pre-hospital side of things. For hospitals that are receiving these patients, do you have any tips, like from the pre-hospital perspective, about what can help to smooth that transition? Like, what makes that transition most effectively? What are common pitfalls that might happen, and things for sites to watch out for, especially sites that may not have a lot of experience or may not frequently receive these these kind of pre-hospital activations?
Just to be clear, are we talking about the patients where we're at the sending facilities where we're picking them up, or at the receiving facilities where we're dropping them off? So
I would say probably for the receiving, well, maybe on both ends. Like, I guess for the transitions that are happening from the hospitals you're taking the patients from, like what are problems that might come up and things that hospitals should watch for to help smooth that transition, and on the receiving end, maybe both perspectives.
Yeah. So from a sending facility perspective, it is really about having the information ready and ready to go. And from a MHP perspective, knowing what's been given and having the whatever additional products we're going to take with ready to go for our crews, so that we're minimizing delay. From a handover perspective, depending on whether or not the patient's on infusions, not on certain infusions, ventilated, that handover can take varying amounts of time. The big thing from a clinical perspective, from an infusion perspective, and this is a long-standing goal, is to try and standardize what infusion nomenclature we use for different types of things. So, sedation or pressors all use the same, weight-based dosing and stuff, so that we're not trying to recalculate or calculate on the fly what the dosing is. But I think having the one of the big things we know is that waiting for blood products does delay the handover and the departure for our crews, and so that in and of itself, having that ready, predicting it, is going to shorten our time to departure out of the sending facility. I think on the receiving end, one of the big things, and it comes back to some of the comment on the slide, is smoothing the process of handing over whatever blood products are not used in transport. Currently, our crews will hand off the cooler to one of the receiving site staff, and so that they can say, like, here's the cooler, here's what's in it, here's what we've given as part of the handoff. So I think that trying to streamline that process at some of the receiving sites, so that that can be accepted back into the blood supply, I think is one thing that it would, and it seems variable. Some places are able to do it, some places generally can do it, but not always. And so I think it trying to standardize that process would be helpful from a systems perspective, only because we don't want to see any product loss.
Mm-hmm. Thanks. For the MH, I guess in terms of kind of the obviously, like Dr. Pashaniak and spoke to a lot of the development that's happened provincially for MHP protocols and checklists and things to help to standardize things. Does Orange utilize some of those same checklists and protocols? Like, is there a bit of integration of those MHPs from the pre-hospital to hospital? Is that?
Yeah, so that is the one thing that we did, was actually try and integrate it completely into our directives, is exactly how to follow the current recommended guidelines within our system, and being able to balance between either, you know, having all products like thawed plasma, platelets, RBCs, or then looking at adding in PCCs, fibrinogen, if those are unavailable. Currently, from a transport perspective, we carry TXA, so we'll make sure that TXA is part of that early management, as well as on some of our craft, and hopefully soon to be all RBCs, plus or minus. Whether or not we get to plasma really depends on utilization and minimizing waste.
Perfect. That answers another question, I think, about TXA. So Orange does administer TXA pre-hospital.
Yes.
On the TXA side of things, I think the question maybe for anybody, Dr. Stone or Dr. Petrosoniak, just some questions around TXA administration, particularly around related to obstetric MHPs. I don't know if you could comment around TXA use, whether it should be redosed. So one question that came up was if it's given as part of the postpartum hemorrhage protocol routinely, should that be redosed if an MHP is subsequently activated? And what is the recommended dose essentially around that? Is it the standard 2 grams, or how should that be given?
I can just speak from our hospital, and then maybe if others have other evidence. We looked at this at our hospital. In the toolkit, I believe, I don't think there was a change for OB. I think it was just 2 grams. We spoke with our obstetricians and asked them about their evidence. It didn't seem obvious or clear. I think typically they give 1 gram, but we left it in our protocol just to give 2 grams up front. I love the 2 gram bolus dosing. It just makes life easier, and we like to keep things simple. So that's what we've done. I don't know if anyone has any other information, or.
I would echo that the 2 grams, you know, and certainly if somebody if there is an obstetrician or an obstetrical expert on the call, by all means, please, we'd love to hear. But from a human factors perspective and simplicity and aligning with something that people, you know, teams can kind of get behind, particularly if you have clinicians working in different parts of the hospital, the 2 grams would be what we would favor in a bolus dose.
Thank you very much. But I think as a reference people could look to is the WOMAN trial, WOMAN, which was one of the biggest randomized trials published in Lancet in 2016 or 2017, I want to say. They did give a 2 gram dose given as a bolus, followed by a 1 gram over 8-hour infusion, I believe, which, so if people want to read that study, helps to answer the question or some guidance for that. Question, I guess, for Dr. Stone. I think this was for Dr. Stone, just around FCC or PCC use and requiring authorization. Can you speak to where that authorization comes from, or who's responsible for oversight for PCC use?
Well, it's fortuitous that Dr. Pendergrass just jumped on screen. He is our medical director. I believe authorization comes from him or whoever's on as, I think, the medical director of ORBCoN. I believe that we just have to get authorization for pediatric fibrinogen, or I believe if we want to redose fibrinogen for adult or obstetric, we give it once and that's fine. If we need another dose, I believe we have to get authorization. I've never asked or had to get it, but it sounds like it's quite a quick process. It sounds like talking to Barb in our lab, this happens within minutes. And so it's not really a roadblock. Maybe Jacob can speak to that further.
Yeah, there was just extra caution for the pediatric application of the MHP. Given that, you know, PCC would be sort of used kind of off-label in that situation. And just because the dosing of fibrinogen is a little trickier with you know, depending on the size of the pediatric patient. But yeah, the general process is if there's any kind of like unusual or potentially risky product request in the middle of an MHP, there's a page to the on-call blood bank medical director, and we've committed to like responding within 5 minutes. And and if we can't get within 5 minutes, the product is just issued. So we've put in try to get that balance between providing that kind of clinical decision support without slowing things down at all. But yeah, for adults, there's no review process. It's really just sort of the range of weights that you can get for pediatric patients means you have to be a little bit more careful.
Thanks so much, Dr. Pendergrass, and thanks for joining the call, putting you on the spot here unexpectedly. Andrew, do you have a comment to make on that?
Yeah, just we will probably, with the 2.0 MHP that will be coming out in the next few months, we will probably be de-emphasizing fibrinogen empirically based on the Cryostat-2 trial. So this will be a push for institutions that can't measure fibrinogen to look to try and figure out ways to measure fibrinogen. Because of the data suggested that empiric administration, just giving it to, now this is in trauma, which would be many of these cases, but obviously separate from the obstetrical situation. But we will be kind of de-emphasizing that a little bit, and it'll be more based on what your levels are. And then so you certainly, if you have a low level, administer it. If you think that the patient really is coagulopathic, they're bleeding from their IV sites or something like that, then we would, in a site that doesn't have ability to measure that, we would probably allow, that's still clinician judgment and probably a good decision. But we just know that there's a bunch of patients who are bleeding massively who don't necessarily have low fibrinogen levels, and the data from Cryostat-2 didn't support empiric administration sort of broadly. So that's just maybe what to expect coming down the pipe. So if you're an institution trying to figure out and navigate this right now, like, it wouldn't be the thing that I would really push hard to have widespread distribution of fibrinogen to all patients, particularly trauma patients. That might be something that may not be the battle you want to fight, because we will probably have some adjustments in the recommendation.
Great, thanks. On that note, just on the idea of the MHP 2.0 and 3.0 and things down the road, the evidence, I guess, around in this space is always evolving. And just a general question for everyone on the panel is, how do you recommend smaller sites, rural sites that, may struggle to even get the activation energy to develop an MHP? How do you prevent it from going stale? Like, what goes in? What do you think would be effective for maintaining it and making sure that things are as up to date as possible, just given some of the constraints with time people have to devote to these activities?
I can speak to that. I think from sort of a collaborative practice, best practice guidelines kind of viewpoint, is identifying that person who is sort of responsible for maintaining policies, procedures, all of that kind of thing within your hospital, and including them in the development process from day one, and then sort of having that debrief group or follow-up group and just keeping them in the loop with everything.
At your site, does your transfusion committee review the MHP periodically? And is that sort of where the responsibility is felt to lie, with the transfusion committee, or is there a separate working group for the MHP to maintain it?
Separate working group. We, again, when in Laura's presentation, she sort of mentioned that we had kept it not as formal, and we found that we were taking over our transfusion committee meetings with MHP discussions, so really identified the need to have that separate working group.
Perfect. Somewhat related question just around I guess development of the MHP, and I think that you touched on, Dr. Stone, you touched on the importance of having the administrative support behind that. Do you have any tips you could bring about how to bring a senior administration on board and get that motivation at that level, and what kind of concerns about costs or liabilities on the hospital end, and how to address those concerns?
I'll let Manda maybe speak to the process of getting the funding for the nurses, because that was incredible, and she can maybe speak more to that process. But I think, getting your leadership on board, I mean, these are preventable deaths, right? These hemorrhaging patients, if you can get the blood products into them, then they don't need to die or have that more significant morbidity. Of course, our obstetrical patients, there is no room for a bad outcome there. And so I think the benefit of this is that you can be passionate. You know, I am an emergency physician. I am quite passionate about this. It's just such an important area of the care that we provide. And I think hospital leadership can hear that. And so I think getting the clinicians who are involved with these patients and your obstetrical patients and your young trauma patients, as Andrew said, you know, that sense of urgency, bring those cases to the table where you've had a bad outcome, and it really illustrates the importance of getting something. And then with ORBCoN and these resources, it's so helpful that you can put something together in a range of something very small to more widespread. Amanda, do you want to add to that?
Yeah, I can kind of speak to the more administrative piece. Is that we did invite our leadership, our director, to one of our run-throughs so that they were really able to see the work that we were putting into it. And we also formalized the process in creating a briefing note and presenting and having our leadership present that to the senior leadership team. So again, just using the toolkit, using all the numbers, and like Laura said, these are preventable deaths. And you know, empowering our staff to be able to respond to this. It really helps with things like retention and, you know, decrease in moral injury, decrease in burnout, all those really big hot topics that, you know, live in this post-COVID world, and, you know, the high staff turnover numbers. So it's sort of a win-win situation.
Great, thanks. A few specifics, I guess, about your MHPs. Some questions about running the blood through a warmer. I think that may be kind of more relevant for some of the, maybe in a rural setting, and resources if those are available or not. I mean, I know I practice here in Ottawa, and having blood warmers are sometimes hard to get on the floor, especially. Do you guys use a warmer, and speak to that?
We do. We use a warmer with high. So if we don't have the rapid infuser, like a automatic rapid infuser at the bedside, we will use a warmer with high flow tubing and a pressure bag in sort of a manual sort of process, but we do warm all of our blood.
And a follow-up question about the porters came up, just around resources you guys have for porters. Do you have 24/7 porters? And if not, who would do the running of the blood off shift?
We're really fortunate that we do have 24/7 porters. I think for some of these smaller areas, when you're looking at the toolkit and looking at developing your team, I have worked in a smaller center. So, you know, what does that response to wherever that MHP looks like? And then maybe you assign a runner that is their job. You know, they're going to go back and forth between the lab and that co-transfusion.
Thanks. Dr. Petrosoniak, you mentioned you practice kind of in a kind of a tertiary care as well as a few rural hospitals. I don't know if you could comment a bit about maybe some of the contrasts that you see in terms of MHP activations between the two, and you know, key differences, that maybe strengths at the rural hospitals that we might not appreciate, and what could kind of be leveraged in the rural setting to optimize use of MHPs.
Yeah, thank you. Great question. And I would just to comment on the previous, or on sort of two kind of questions ago around empowering people, you know, to do this kind of work. One of the things that we've had success with, and I would encourage, you know, institutions to do so, is have a clinician send an email after an MHP that went very well. Celebrate the successes, name the people that were involved, name the clinicians that were at the bedside, and send that to hospital administration. We don't get a lot of thanks these days, I think, in healthcare, or not enough that we deserve. And I think celebrating that, you want to talk about retention, and, you know, I've done that before, where we'll send it out after an MHP went exceedingly well. Blood, you know, ended up in the trauma bay very quickly, and you put in a few metrics, you know, TXA in within a few minutes, all of those types of things, and celebrate the successes of your staff, that goes a long way. Both, you know, CEOs love to see that kind of thing, right? I mean, those are metrics that matter to them. And it's a way that they can then show that their hospital is, you know, meeting or exceeding these types of things. So that I just kind of put that as a plug that I've, you know, and if you have a, particularly if it comes from a physician lead, I think that is a great thing, because that you know, despite the unintended hierarchies that exist in the hospital, there are still, you know, the physicians do, you know, are often seen as leaders in that setting, but it could come from anyone. The differences, or, you know, what I've seen in smaller centers compared to larger centers, I do find that sometimes, you know, you almost have to give away your firstborn child to get some blood sometimes in a smaller center. You know, we've in larger centers, it tends, I don't run into that problem at St. Mike's. Katarina's made it very streamlined for us, but it can be a struggle. Or as we've talked about, getting those adjunct products, you know, and that certainly is a challenge, and one that I think shouldn't be something that we try and fix in the moment. You know, can I get PCC or not quickly? And, you know, who needs to authorize that? That's something that should be identified and then happen around, you know, during the daytime hours and figured out, you know, via meeting. Where I see there's a ton of strengths is getting in TXA quickly, getting transport out, particularly, you know, that's where there's real value that can be brought to the patient, getting a couple of units of packed cells into the patient and just keeping them warm, like we talked about. And if you can do that, and those are what I've observed, you know, that's where there's meaningful impact in starting the care for the bleeding patient, because it's really not just about transfusion. It's about understanding that the patient is bleeding, and how are we going to correct their coagulopathy that happens, in addition to, you know, how are we going to definitively manage that down the line. And so I think those are things that I've seen, you know, institutions do really well in smaller centers, like just get in the 2 grams of TXA, because by the time I see them when I'm at St. Mike's, it's 3, 4, 5 hours later, and we're outside of the window of, you know, the value. So.
Great, thanks a lot. Yeah, I certainly like that message of celebrating the positives, because I think it's easy to kind of go through these things and focus on what do we not do right, but, you know, making sure to recognize what went right and emphasizing that is I think really important as well.
Can I just add really quickly? We do include that, celebrating like good news and recognition, in our debrief, and our frontline staff are invited to the debriefs. If not, it is carried forward to them as well from the leadership that attends. So that was helpful to identify. Like you said, we always talk about what went poorly or where we could improve, but we also include the what went well.
Thanks.
And Johnny,
Pendergrass, I think you had your waiting patiently. You want to go ahead?
I was just going to make a quick comment. I think just building on what some earlier comments were made about, I guess the question was like, how do you sort of overcome the institutional inertia to put in a protocol like this in the first place? And I think it's fair to say, and I'm speaking from sort of the lab side of things here, the clinicians are often very motivated to have protocols like this developed. There's always a risk of some nihilism setting in on the blood bank side. When you talk about putting in a massive hemorrhage protocol, when you look around and there's 4 units of red cells, or like, how could we possibly have a protocol when there's not, you know, enough blood to sort of even like half resuscitate, you know, a whole blood volume. And, you know, that's a fair consideration. And so there's sort of this feeling of like, the only protocol we need is you know, how to get Orange to come and pick this patient up as quickly as possible. But I think, you know, there's a couple of considerations. First of all, there's blood that can be brought to you faster than historically it might have been the case. You know, I think there are partnerships you can develop with local hospitals to help you out. Orange, with their Blood on Board program, is again sort of accelerating the provision of blood locally while you're making efforts to get the patient out. And also, I think what I really liked about Laura's presentation was she emphasized how important it is to have the logistical machinery in place to support this patient. You know, everything involving, you know, how do you, you know, get source control? How do you get the anticoagulants reversed? how do you get, the resuscitations, initiated, the tranexamic acid given? There's so much that needs to be done beyond just the blood products. Absolutely. You need blood to sort of manage a patient, but even if you only have 4 units in the shelf, there's still so much improvement that you can achieve. And I have to say, I mean, I've seen some massively hemorrhaging patients who died, and it wasn't from lack of blood products. That's not what the issue was. And it's important to keep in mind that there's so much good that you can do, even with a small local inventory. So I think once the blood bank, really gets on board with that idea, saying, you know what, this is worth pursuing, that even if we only have a small inventory locally, then you can kind of get that crosstalk going. And that's really what the transfusion committee is for, is to be that meeting place between the clinicians and the lab. And then of course, if it really takes off, then you create your working groups. But it starts with the transfusion committee. That's where the blood bank and the clinical services meet together and say, we have to figure something out. And then if you're lucky enough to have, champions like we had at Sioux Area Hospital, it quickly takes off. So I think it's something that everybody can do.
Absolutely. Thank you for those comments. I think that's sort of bears emphasis, I think, and that came across in Dr. Stone's talk, just about the blood products are one component of the MHP. I think sometimes we think of MHPs as being just this conveyor belt of blood products coming up, but it's so much broader than that. And I think the provincial MHP development that's happened, I think, has also emphasized that. So it's really critical to take that broader view of MHP support being really a system supporting that patient, and blood products being a part of that, but not the only focus. We touched on a little bit about, I guess, concerns around, you mentioned Dr. Petrosoniak having to give away your firstborn child to get blood products at smaller centers. Shift over to you, Dr. Peddle. There's some questions around kind of related to that. Maybe to start off with, question came up about remote hospitals and having limited stock that might be supporting Orange or the patient as they're being transferred. Can you speak to how you manage kind of impacts that Orange might have on that hospital stock, and how you manage blood product turnover and stock maintenance for remote facilities and maybe within Orange itself?
Yeah, so I think from an Orange perspective, our goal is to minimize the number of products that we're going to take from a facility, because we recognize a lot of the places we go have very limited stock, and that's one of the goals of our Blood on Board program is to be more self-sufficient, at least for some of the products that we're bringing. So I think our goal there is to try, especially with our red cells, to limit the amount of stock that we have to take from the sending site. The challenge for us is really about the capacity to take more than for our crews to store plasma or any other blood product, either at the base or in our aircraft, from a weight perspective, from a utilization perspective. And therefore we are somewhat dependent on some of the smaller sites to provide us with either PCCs, fibrinogen, or plasma, depending on what's readily available. But I think it is a balance of trying to ensure that the products that we take from the sending sites are going to be products that are needed for transport, and then being able to take some with us. A lot of from our Thunder Bay site, as I mentioned, if we've identified that the patient is likely going to require more than 2 units in transport, they will bring additional coolers with to try and limit the amount of RBCs that we have to take from the sending site. The other comment I did see a question about is the exchanging of coolers at remote sites. That is something we started to look at. Like I said, fortunately, in a year and a half of running the program, or almost 2 years of running the program, if we include our rotor time, we've only had this happen once, where we lost a cooler because the crew couldn't get back to base. And that's part of our 48 to 72 hour turnover, but recognizing the coolers can go to 96 or almost 100 and just over 100 hours. So generally we are able to get them back to base. Our hope is as we roll out our Blood on Board program at all of our bases, part of the ability then will be is if you, for the most part, we duty out at one of our dedicated sites. is that we'll be able to develop processes with each of those blood banks to return blood that isn't going to make it back to the host site. But so far, fortunately, we've only had one event where we've had to lose a cooler.
Great. And just on that note, I guess the direction of blood, I guess, in terms of, the Orange team would have a cooler, they go to the receiving site with that cooler of blood. I think one of the questions asked about the exchange of units, but there isn't an exchange that's happening really, right, with the blood products from the receiving hospital to Orange. Orange is taking that blood, either dropping it off or bringing that same box back with them, not really trading blood with the hospital. Correct.
So we don't restock blood at the receiving site. All of our restock of blood is done with the blood bank that's aligned with that base. So in Toronto, it's the Sunnybrook site. And so we restock our blood supply once we get to return to base.
Thanks. And related to that, just with the introduction of whole blood, can you comment on maybe how you think that might impact wastage, if that's going to result in increase, decrease, no change?
Yeah, I think that I don't have a good answer to that question, to be honest. And I mean, the whole team is looking at how are we going to minimize waste of the whole blood product as part of this study, is to look at we recognize from a utilization, we know roughly what our utilization is going to be from a trauma activation between April and through the fall. And so there's definitely going to be unused units as part of the study. And so we're developing processes to ensure that they are, or to minimize the waste of that product if it's not going to get used in the actual sort of pre-hospital environment. But to comment on how much of it, I don't know. And it's going to be one of the things we're going to look at as part of the study.
Right. Yeah, it's a big question, I think, for the introduction of this product in Canada in general. And there's a lot of thought going into how to most effectively use the whole blood to avoid that wastage and make sure that we're not wasting that precious resource. Could you comment on, I guess, how you think whole blood might fit into a rural type setting where there may not be availability of hard to maintain, like a platelet inventory, for example, and how whole blood might fit into that?
Yeah, and I mean, that is a great question. And I think that is where we can potentially see the utilization of whole blood, or being able to have whole blood in the transport environment might have the benefit, because you're taking all of your product in one cooler, and you're not necessarily impacting the local labs or sites that actually, like, if you go to all of our nursing stations in the northern part of Ontario, they don't have any blood. And so I guess the question then becomes is utilization and how the product is utilized, what the wastage is, because it obviously, and Johnny, you know this far better than I do, has a much more limited shelf life and ability to be used in other ways. And so I think that is going to be one of the things that we have to look at, is as we, from a system perspective, determine whether or not it is viable to put it in other sites and put it in the pre-hospital environment.
Mm-hmm. Yeah, just for those out there that don't know, I think the whole blood, the shelf life is 21 days. So it does have a better shelf life than platelets, but not as good as our red cells or plasma components when they're frozen. And I guess to be determined if those platelets that are in there, we know they decline over time, whether that impacts their ability to contribute to the bleeding patient, and if that's any better than the components or not, I think it's still a bit of an uncertainty. So lots to explore on that side of things. None of you are off the hook yet. There's a lot of questions that have come in. You got your talks I think, generate a lot of thought, which is always great to see. We'll shift gears a little bit to sort of talk a little bit maybe about the administration of blood products. Maybe since I have you on, Dr. Peddle, and it kind of fits nicely with sort of the order of where patients flow through the system. When you're administering blood products with Orange, how is documentation handled, and how does that transfer to the receiving sites?
For sure. So all of our documentation is through our EPCR system, which is essentially an electronic medical record program that the paramedics document in. Every time they administer any blood product, so regardless of which it is, they have a blood product transfusion code that they enter into the EPCR that then fills a number of fields that they have to complete. And that will include the unit number, so what it is, what product they're transfusing, the unit number that they're transfusing. We're just updating the system to include some other variables for the SWIFT study as well, but whether or not it's blood on board, blood that we received from a sending site. And then a number of questions related to documentation around transfusion reaction, temperature, and the ongoing monitoring of the patient. So all of that is captured within our electronic patient record. Electronic patient records are sent to the receiving site. So the hospital that receives the patient is automatically sent the electronic patient record. It is done through direct email to their health record. So the receiving site does receive that information, but it is very dependent on the timing of processing of the health record into taking our electronic medical record document and then putting it into the patient's medical record at the receiving site.
Okay. And is the disposition of the transfused units that gets communicated through that record?
Yeah, so anything that is transfused will be in that medical record. So if we've taken a cooler of multiple products, anything that we've transfused is in that, and then anything that we haven't used generally is a commentary piece on the EPCR. They'll say like a cooler had X number of products. You'll see which ones were transfused, and then they say like the cooler was handed off to receiving site at, and they usually put a time as to when they handed the cooler off.
Thank you. On that note of I guess transferring the accountability, Dr. Stone, this question came up about patients. You know, obviously these MHP situations are quite fluid. Patients might be in the ER and then moving to the OR or over to radiology. There's a lot of movement that's happening. How are you transferring accountability, and how is that documented? A question around that.
Yeah, so all of our blood products are documented in our electronic record. And so there is an area where you can look and see all of the products that the patient has had. So right now, that's the tool that we're using in terms of the number of blood products. In addition, we're very clear there's also a verbal handover, right? And there's a physician-to-physician handover, as well as a lead nurse to lead nurse handover. And that may in the operating room be to the anesthesia assistant or somebody else, but kind of a two-person verbal handover in addition to the documentation of the blood products in the computer.
And the checklist that you showed that was like generally that was very popular, a lot of requests around those checklists. Are those transferred with the patient from kind of most responsible physician to most responsible physician, or does do you guys have your own versus another checklist that might be in the OR or anesthesia group?
Yeah, that was a tricky kind of sticking point because there's such a push to have everything on the computer. We wanted to be very clear that we're not actually documenting anything on there, and there's not actually a physical piece of paper or something that's going with them. Logistically speaking, no, that kind of algorithm I think stays wherever, you know, in the emergency department, and they wherever they're going, say to the OR, they would have their own separate algorithm. And we're kind of trying on purpose not to transfer information on that because it's really we don't want information to get missed, right? Someone think that they put information on that piece of paper and then it actually doesn't get put in the computer. So yeah.
Right.
Manda, I think, has something to add there. Please jump in.
Hi, I just wanted to speak from sort of the nursing point of view as well. So we don't want anyone to have to double document. And because all of our documentation is in our EMR, in the protocol that is attached to the order set, we have included what needs to be under the TOA piece, what needs to be discussed during TOA. And then we have an intervention within our EMR that is a transfer of accountability intervention. So that is where you're getting sort of like the nursing documentation of what has been communicated.
Yeah, thank you very much. Question maybe for all three of you, or maybe Dr. Petrosoniak and Dr. Stone and Manda, about patient identification, I guess, when you have MHPs, do you include the patient ID information on the RBCs, or these, you know, a lot of these situations you may not have that patient information. So how is that identification, the chain of identification happening?
That is a good question. I think I would.
That's why I brought Amanda, Andrew.
Yeah, these are detail. I'm not a detailed person. I do know that this has been extensively discussed. So why don't we at our site, but I can't remember exactly what our process is, but we run into the John Doe, Jane Doe situation on a regular basis, particularly for our trauma patients. We do know that we won't change identification for a while until blood has stopped being issued. So we don't change in the middle of an MHP if it is an unidentified patient. And so there's a pause in sort of the clinical care that's kind of happening, or the pause of the administration of blood products, but probably Amanda might have better ideas here.
You're correct. So same with us with the Jane Doe, John Doe. We don't change even once we've had positive identification until the MHP is terminated. We document everything under that account. So we really push. That was why the electronic order system development was so important, is because we really do encourage our staff and having that lead RN there to refer to the protocol, getting the orders into the system so that our lab is able to, label everything safely and follow their accreditation standards.
Okay. Thanks a lot. That was a bit of a nuanced question that may not all have the insight into. Apologies for that. In terms of I guess documenting the MHP cooler opening and making sure that those units can actually go back to the lab. How are you keeping track of when the cooler is opened, and sort of when the clock is starting for units that might be removed from the cooler, to make sure that they're within the time frame that the lab can take them back?
We track all of our numbers from the time that the porter arrives in the lab to the time that the blood arrives at the bedside. And then again, using that EMR standard, we're scanning our blood products into the system. And we get our blood returned to the lab as soon as the MHP is terminated. That is one of the portering duties.
Okay. And I imagine any units that you're not planning on transfusing would just stay in the cooler, and so that those have been validated to keep them at a certain temperature, right? So that's.
Yeah, I can't remember what the amount of time is off the top of my head. Sorry.
No problem. Are you guys using your electronic record for all of your MHP documentation, like any medication administrations, blood administration, everything is documented electronically, nothing on paper?
No, we try to avoid that because before we had the electronic order set and everything built, we were finding that the staff at the end of an MHP, so wherever the patient ended up, they would have to go in and try and back document, often on things that they did not give, blood products they did not give, medications, that sort of thing. So we were finding there were a lot of gaps in documentation, which is never good. So we really wanted to make it a real-time process and as user-friendly as possible. So within our EMR, we're able to scan to order medication vials. So that's, what it makes things a bit easier. And then that's your documentation as well.
Perfect. And then a question about lab testing. There was a specifically for maybe for you, Amanda, or Dr. Stone. I don't know if Dr. Pendergrass could speak to this. Just about having a protocol if you're not able to get a hemoglobin because it's so low, it's outside the measurable range. Like that's come up for this question, the person asking this question. If that's ever happened, and how you approach that if you're not able to get actually lab values, how you handle that.
I'm not aware that that's ever happened. Jacob, you can let me know if you've ever experienced that. I'm not sure. Again, certainly in the emergency department, we're often activating these before we have lab results available and going ahead with the protocol without a hemoglobin. And often your first hemoglobin, you're not quite sure what to do with that anyway. And so it hasn't impacted me as much than that I can recall.
Yeah, I think, I've never seen that either, where a patient who is still alive had a hemoglobin that was so low the machine couldn't even detect it. But we would never, I mean, you would be transfusing red cells regardless, in the beginning of an MHP. There have been cases, I was involved in recently, where the lab noticed that a CBC the sample itself looked really dilute, even just spinning it down, it looked anemic. And even before they had resulted the hemoglobin, they called the clinical area and said, you might want to check your patient. This looks really, and sure enough, that patient was hemorrhaging. So certainly I think if you have any sign in the lab that this patient is severely anemic and an MHP has not been activated already, then call and tell them, like, something is wrong with this patient. I just want to make a quick comment about the issue about discarding returned products. Generally speaking, like I think, Johnny, as you said, if the units come back, in a cooler within the time period that cooler has been validated for, which is typically like 4 hours, and it's still within acceptable temperature range, we take it back. We don't ask that somebody's policing to see was the cooler opened or closed, whatever. We just we don't micromanage that kind of thing. The issue that we've had problems with discards is with the thawed plasma, and the reason is that when you thaw it, and it's not used, it comes back warm, like at 37 degrees, and at that point you can't use it because it's too warm. It's okay, you can keep refrigerated plasma for days, like if it's kept at 4 degrees, but once it's up to 37, if it's not used, it's going to end up getting chucked. And that's why there's always this kind of caution about thawing plasma too soon in an MHP, because you don't want to waste it. This is another reason why a lot of protocols also really push for the early use of non-SD plasma to begin with, both because it's a little faster to thaw, but also because if you thaw it and it's not issued and you just put it in the fridge, we found historically that it keeps better. Once you have thawed SD plasma and you put it in the fridge, you're more likely to start seeing precipitate. Just anecdotally, we see stuff kind of precipitating within it, and then we have to end up chucking it anyway. This is one reason why we think it's a good idea to have a little bit of non-SD plasma right at the beginning. You can transition to SD, once you're sort of underway and you realize you're definitely going to be using it. But that's something we've kind of had to negotiate with Canadian Blood Services, who have been trying to get everyone to transition predominantly to SD plasma, which is definitely a safer product overall. But in an MHP setting, there are there's an argument to be made that having just a little bit of regular plasma just to start you off means you're not going to be waiting as long and you're not going to waste it as much. So that's just one comment, but it's another thing as well. Like if you can tell the lab start thawing your regular plasma, but put it in the fridge so it's refrigerated, then that sense you can keep it for a few days at least, even if you don't end up issuing it. But once it goes out in the cooler at 37, if it's not used, it's going to get chucked.
Mm. Just maybe that's a good point to question to bring up, I guess, is that your sites, are you thawing plasma in advance, or are you only thawing on demand? And it sounds like you guys are using plasma, not SD plasma. Is anybody using SD plasma in their shifted to their SD plasma for their MHPs?
Once an MHP is called, we start thawing, and we start thawing with regular plasma. We don't issue it right away, until there's truly like a need to get it. But when an MHP is actually underway, we've committed there has to be thawed plasma available at all times. So as soon as 4 units go out, another 4 go into the water bath, just so there's always something available. But again, it's the issue is you don't want to issue it until you're relatively sure it's going to get used, just because it doesn't, gets chucked otherwise. But we do try to have plasma thawed right from the get-go. But we don't have plasma thawed sitting there all the time just in case an MHP is activated, because that probably would also worsen wastage. Again, this just gets back to the communication. It's like, it's a good idea to know if a patient is starting to look a little wobbly and this might turn into an MHP. But we do ask clinicians, like, don't actually, pull the alarm and call it code transfusion until you're pretty sure that you're at that point where you're actually going to be using the plasma you're transfusing. You can ask for cross-matched red cells. You can say it's an emergency, but an MHP is kind of a whole separate thing, and that thawing of plasma is kind of the that's kind of the dividing line. When you're at the point where like, we're going to need plasma for this patient, that's when you're sort of getting into MHP territory.
On the note of activation, a good question was came up. I think I'm understanding this. Just mentioning the I guess the activation criteria in the MHP toolkit, the provincial ORBCoN toolkit, versus the recommendations that were touched on around three units. Like if I understand the question. So the question is, did your policy state the activation recommendations identified in the toolkit, or are the activation recommendations considered at after 3 units?
I can start on this, and then I'll hand over to the expert himself. Talking about trigger and the difference in the policy, I think, versus kind of what you practically do. It's hard to write kind of your approach to triggering an MHP in a policy and a protocol. And so we did kind of outline some of the things from the toolkit, as in, looking at your shock index, or if you've given 4 units of packed cells, those are, things to think about when starting your MHP. But again, that idea of the critical administration threshold, starting with kind of 3 to 4 units, and then before you've activated your MHP, seeing how the patient does, and then reevaluating and saying, now that I'm on my 3rd unit, are they still bleeding and still unstable? If so, go ahead with your MHP. And again, I'll let Dr. Petrosoniak talk about that great work, because it's all their educational and ORBCon's, that educational material that I've found so helpful. But as I said, at our hospital, so we did change it so that we can get 4 units of packed cells just based on EMS patch. And we made it 4 units so that corresponds with really the initial cooler, right? So if we get that 4 units of packed cells down, we've hung that blood, we end up activating the MHP once we're on the 3rd or 4th unit. Then the lab knows that now we've activated the MHP, we're on to our standard cooler. And so that has worked out quite nicely for us. Andrew, I'll let you comment further on that.
Yeah, no, that's great work, Laura. And I agree with everything that Laura and Amanda have been doing up in Sault Ste. Marie with that. We will have amendments or adjustments with MHP 2.0 to reflect this a little bit better. We were purposely, I guess, deliberately vague in the current recommendations, because there's really a lack of evidence to guide this. So for those that have been following how to decide on the decision making around activation, there are a few scoring tools that are best linked to trauma activation for MHP rather than for obstetrical or GI hemorrhage or other non-trauma causes. So there's a bit of an absence of evidence in that sphere. In the trauma space, the scoring tools are not particularly great. They're okay. They might hit the mark, 70, 80% of the time, but that means a 1 in 5, maybe 1 in 4, you're going to activate or be wrong with on either side, overactivation or underactivation. And so we really will be pushing out this idea of a critical administration threshold. The literature uses 3 units. If you want to make it 4 for the ease, and that's what we'll recommend probably in the next iteration, 4 units to align with your sort of pre-activation pack. It will function as a bit of a speed bump, as Jeannie Callum likes to call it, to sort of allow the team to kind of pause and reflect, like, do we need more? And as Jacob alluded to, then it's a full court press of like, okay, we got to thaw plasma. We got to get, the next set of products going. But we would rather not initiate that whole resource allocation unnecessarily. I see these patients a lot at the bedside. I consider myself somebody that like spends a lot of time thinking about this stuff. And I'm not very good at predicting who's going to need a bunch of blood and who's not going to need a bunch of blood. Even though I know, oh, this patient's clearly bleeding, I'm going to start with a couple of units. Some respond beautifully. And some you're like, wow, I didn't expect you to get that sick and really fall off the cliff like that. And so we know that from the proper data, when they went back and looked at surgeons predicting need for MHP, like they were like 65%, 66%. They were like 2/3 of the time right. And so using a critical administration threshold or something along those lines, a pre-activation threshold, will be key to building friendships from clinicians to transfusion folks so that you're not over-activating. But that's going to be something we're looking at longer term, and we literally just had a call about this yesterday with the ORBCoN and our MHP 2.0. So look for more of this, but if you're looking to do something now, yeah, follow what Laura kind of outlined in her talk that I think is meaningful and tangible, and you would be well within the evidence.
Great, thanks a lot. Just in the last 5 minutes we have for questions, and I really greatly appreciate you guys sticking around for this panel discussion. I think it's been really informative and a lot of things that have come up kind of nicely in the discussion that are quite important. There are a few questions that we haven't got to and a little harder to lump in together. I'd like to try and go through them, maybe just rapid fire one by one so that we're not leaving any questions unanswered while we have this great combination of knowledge on the call. First off is I guess around maybe for Dr. Stone or for Amanda, just about use of warmers and plasma and platelets. Do you use warmers for those products or not?
I believe the only product that we shouldn't warm is platelets. I think everything else does get warmed.
Yeah, that would be in line with recommendations as standards. I think platelets are not recommended to go through a warmer, but so you guys are using warmers for plasma, but not for platelet products. Super. Dr. Peddle, regarding the Blood on Board program, you mentioned Toronto Thunder Bay. As a question, is it available in London currently, or are there plans to have it expanded to London?
Yeah, so specific left London out. We are hoping to go live in the next couple of weeks in London, but currently, as of today, we're just live in Toronto and Thunder Bay.
Super, thanks. A question for Amanda about the use of level 1 rapid infusers in ED. Do you have one staff member that's assigned to them to monitor and operate, or multiple people? Is that a role that's shared?
No, the blood nurse is responsible for the operation of that rapid infuser, whether we're using the manual method that I spoke about earlier, or whether we're using the automatic. Just because the infusion rate is so high, there's risk if you are distracted by doing something else. So we really keep one person doing the blood administration.
And at the Sioux Area Hospital, what Meditech system is used? You can speak to that.
We're Expanse, Meditech Expanse. So yeah, we're part of the One Initiative.
Okay, thank you. And then a question for Dr. Pendergrass, even though you're not on the panel. Type and screens performed, screens positive for an antibody. Are you switching to type specific or sticking with uncrossed matched blood?
Thank you. Yeah, I think this very much depends on what we know about the patient's antibody history. If we know what that antibody is from a previous investigation, then we would be reaching for antigen negative blood for that particular antibody if we could get it. And if we don't know what it is, if there's time to do a serologic cross-match, then that will give us a little bit of reassurance whether it's compatible or not. If there's no time to do any of this, if this is just a positive antibody screen, we don't know what it is, there's no time to cross-match, that's when it's useful to have a quick phone call between the blood bank medical director and the clinician running the code to say, this is the situation. I can't guarantee you that unit is not going to hemolyze. Try transfusing it kind of slowly, watch your patient carefully. That being said, it is standard practice in many protocols that once a patient is truly massively hemorrhaging, like the blood is pouring out of them, then you don't need to worry quite so much about full compatibility for minor blood group antibodies. The idea is that the antibodies that are in the patient's plasma are being rapidly diluted out anyway. The blood that you're transfusing is, decent chance it's going to bleed out anyway. You definitely want to sort of monitor your patient after the bleeding is resolved to see if any residual blood is hemolyzing. But you don't worry so much about those minor blood group antibodies. It's definitely worth a quick conversation. Just got to talk about, can you give us a few more minutes to finish the cross match or what have you. But never let your patient bleed to death over that. That's for minor blood group antibodies. Major blood group, that is a third, you never cross that line. If you have somebody who is group O and you've run out of group O red cells, it is not the right thing to do to get that person group A red cells. That could just finish them off. So that's a different thing altogether. But for a minor blood group, depending on where you are in the briskness of the bleeding and how long it takes you to do the compatibility testing, sometimes you can let that part go.
Thanks a lot. Yeah, I think that discussion is really important just because it is about, comes down to a balancing of risks, right? In terms of what's the higher risk, the risk of bleeding out or the risk of having a hemolytic reaction, and kind of having that decision that's hard to make within the lab and at the bedside. So having that discussion is super important. Super. Thanks a lot. Everyone exhausted? Made it through. It was a marathon question answer session. I really would just like to thank everybody again. I think we had three excellent speakers, excellent discussion at the end here. I learned a lot. And thank you, Dr. Pendergrass, for joining spontaneously and taking some questions as well. Would like to, as we wrap up here, just acknowledge support from Canadian Blood Services and the Ontario Ministry of Health through ORBCoN for providing funding that supported the symposium. Again, just mention that the views expressed don't necessarily reflect those of the Ministry of Health or the Government of Ontario. I'd also like to thank the organizing committee for the event. That definitely would not have happened without them. And you can see individuals listed here: Amanda Nouri, Dr. Roos, Julia Gilmore, Dr. Yunus, Ruth Sebastian, Sheena Schurman, Tracy Cameron, Valerie Rayom, and Dr. Jalevi. We've been meeting as a committee since I think September, Valerie, Tracy, Sheena have just been keeping us on task. And if it weren't for their dedication to putting this event together, I think it just would not have happened. So a big thank you to the organizing committee and their dedication to this. Thank you to everyone for participating and paying attention. There is an evaluation survey that you could fill out to get your certificate of attendance. You just have to scan the QR code and that should link up with your device. And if you have any feedback about how we could do things better, also things you liked, as we mentioned earlier, those are always nice to hear. And if you have any ideas for next year's event, that topics you think are important to cover, that's really helpful for the planning committee. So with that, I will again just express my sincere gratitude to the speakers and everyone involved, and I think we will close things here.